Good morning. So you are the heroes who are here early in the morning after the party yesterday. Well done. And okay, and so you're here for quite a complicated lecture because we're going to talk about autoimmune diseases. They are very important, very much studied in dermatology, but they are rare. So just to give you an idea, pemphigus foliaceus in the cat, which is the most frequent autoimmune disease, it would be maybe only about 0.5% of all feline cases that we see. So I see, no, maybe a little bit more, 5%. I see maybe 200 cats in a year, and I may see 5 cases a year, the pemphigus. So it's not very frequent. Autoimmune disease is not just pemphigus. There are several targets in the skin that can be the target of the production of autoimmunity, of the production of autoantibody. And here I have summarized them. There is autoimmunity against the desmosomes, which are structures in the epidermis. So it is an autoimmunity against the epidermis. And this is pemphigus. And this is what we're going to talk about, because that is the most frequent disease in cats. But we also have autoimmunity against the basal membrane. This is the structure that will connect the epidermis to the underlying dermis. And then we have an autoimmunity against the keratinocyte, and that is lupus. But there are hardly any cases of lupus described in cats. So I'm not going to talk about that. You see it in dogs, these noses that yesterday Elisa showed you. This does not happen in cats. And then there is autoimmunity against melanocytes, and then you have vitiligo. And vitiligo, you see it in the Siamese cat, and it is very similar to what Elisa showed you yesterday with this depigmentation. You know what vitiligo is. So we're going to concentrate, in fact, about these two types of autoimmunity, and we will start with the first one, the desmosomal autoimmunity. So what are desmosomes? Here is a scheme of the epidermis. This is the basal membrane. Here under there is the dermis. These are the basal keratinocytes. These are the keratinocytes of the stratum spinosum. These are the keratinocytes of the stratum granulosum, and this is the horny layer, so the corneocytes. Now you can appreciate that between the cells there are these attachments. These attachments are the desmosomes. And in this type of autoimmunity, the autoantibodies that are produced against the desmosomes. And what happens is that these desmosomes get destroyed, and then the cells, they will detach one from the other. And this process is called acantholysis because this is the spinous layer. It's also called, akanthos means spine in Greek. And so it is the lysis of the spines. These are sort of thorns between the cells. These cells that become isolated, not attached one to the other, they are called acantholytic cells or acantholytic keratinocytes. Please do not call them acanthocytes, because acanthocytes is a special type of red blood cell with a special shape. It's not the acantholytic keratinocyte. Okay? Now we see this a little bit better. This is a keratinocyte with the nucleus, and this is another keratinocyte and another keratinocyte. And here you see the attachment of the desmosomes between the two cells. Here you have one keratinocyte, here you have another keratinocyte, and this desmosomes is formed in a quite complicated way. There is a plaque inside the cell that is connected to the keratin filaments. This is the cytoskeleton of the cell. On the other side, we have another plaque connected to the keratin filaments, and between these two plaques, there are molecules that go in the intercellular space, and they attach one plaque to the other. These molecules in the intercellular space that make the attachment are called cadherins. And they are of different types. We have desmogleins, we have desmocollins, and we have desmoglein 1, 2, 3, desmocollin 1, 2, 3. Now, why am I saying this? Here you see another scheme. This is the keratin filaments in the cell. This is the plaque. This is the cell membrane of another cell, and these are the intercellular cadherins. You see, these are molecules that will bind the two cells. Desmogleins, desmocollins. Why am I talking so specifically about these molecules? Because they are the target of the production of the autoantibody in pemphigus. And desmocollin 1 specifically is expressed in the superficial epidermis. Desmoglein 3 is expressed in the basal epidermis. And this is important because desmocollin 1 is the target of pemphigus foliaceus, while desmoglein 3 is the target of pemphigus vulgaris. These are two separate diseases. Desmocollin 1 is expressed in the superficial epidermis. We will have a superficial lesion. You see, here is the stratum corneum. Here under is the basal membrane. This is epidermis, and so the lesion is very superficial, while pemphigus vulgaris is expressed in the deep epidermis. Sorry, desmoglein 3 is expressed in the deep epidermis, and the lesion of pemphigus vulgaris is deep. You see, the whole epidermis is above the lesion. Here we have a cleft, and this is the dermis. So this was a sort of an introduction to let you know how these lesions work. Now we start with pemphigus foliaceus. So it is a superficial lesion, and also the typical lesion is a pustular lesion. Because you see that we have the detached cells. You remember that these cells will detach because there is destruction of these binding desmosomes. But there is also a lot of neutrophils in the lesion, and this is a pustular lesion. In fact, this happens in every animal with the exception of humans. In humans, these lesions do not have neutrophils. They are not pustular, but they are vesicular. But they are pustular in cats, in dogs, in horses, in goats, in all animals where we know about pemphigus. So, because this is a pustule, the lesions this is a dog, of course, are macroscopically pustules. You see here, there is pus. When these lesions dry up, they will leave some yellowish crusts because this is dry pus. When you see yellow crust, you know that there was a pustule. And in dogs, there's only two diseases that give pustules. One is pyoderma, 95% of the cases, and one is pemphigus foliaceus, the other 5% of the cases. The other pustular diseases are so rare that I don't even mention them. But we're not talking about dogs, we're talking about cats. So what do we know about pemphigus foliaceus in cats? Now, as I said, it is the most frequent autoimmune disease, or maybe the only autoimmune disease that we may find. And there have been many cases that have been reported until now, and it is about 1% of all skin diseases, so it is pretty rare. Do we know the real target of the autoantibody production in cats? We don't. We know that in dogs it was desmocollin 1, in cats we don't. We know that there are autoantibodies that are produced. We know that the target of these autoantibodies is in the skin, but we have not identified yet what precise cadherin is the target of pemphigus in cats. These are the first studies that have been conducted in cats, and this is a pretty recent article, 2020. When I said yesterday that the cats don't have a place in research, this is what happens. We know everything about pemphigus in dogs. We don't know much about cats. So these are the circulating autoantibodies. These are cats with pemphigus foliaceus, and you see that the level of the autoantibodies is very, very high. And these are healthy cats. These are cats with atopy, and the level of autoantibody is very, very low or zero. So we do have these antibodies that are produced. What is the target? This is a immunofluorescence staining of the autoantibodies on the skin. And we see that these antibodies are all around the periphery of the cells. You can see it is like a net. So this immunofluorescence staining is at the periphery of the cells. This means that these autoantibodies, they attach to some structures that are on the surface of the cells, and that most probably is the desmosomes. Because in fact, what we see histologically, cytologically, clinical, is identical to the pemphigus in dogs. So most probably these are also cadherins around the cells in the desmosomes. So do we have a breed predisposition? Again, the cases are so few and the breeds are so few in cats that we don't really know. Reported breeds that have pemphigus, maybe a predisposition, are the Siamese, the Persian, the Burmese, the Himalayan. This is the domestic short-haired cat. Median age, 6 years, but remember, we can see it also in kittens. This was a kitten that we have seen some years ago, from 4 months to 16 years. When I see it in kitten, many times it is induced by the vaccination, so that can be a drug-induced pemphigus. Female to male ratio, 1.4 to 1, but this is not significant. And as that, usually it's spontaneous, but we can have some drug-induced pemphigus, and there has been also one case of pemphigus that was as a paraneoplastic syndrome induced by a thymoma, but that is pretty rare. So let us see the lesions. As I said, pustules. Now the skin of the epidermis of the cats is very, very thin, so the only place where you really can find pustules is on the foot pads, where the epidermis is thicker, because otherwise the pustules, they will break very easily. So here you see a nice pustule, here you see another nice pustule on the foot pads. When you see pustules in cats, you just think pemphigus, because there is no pyoderma with pustules in cats. And then we have very rarely nice pustules on the body, but these break very, very easily, so it's not so easy to find them. And then we have crusts, because when these pustules, they dry, we have the crusts, we have yellow crusts. When you see yellow crusts, you think there was pus. And here also yellow crusts in this case. And then we have, when the crusts fall out, we have erosions. And here you see the erosions on the nose, erosions on the abdomen. Here you still have some yellow crusts, but when they are taken away, they will leave erosions. What is the localization? And that is very important, because this is really, really typical. When you see this localization, you must think pemphigus. The pinna, particularly the inner side of the pinna, but also the outer side, very important. The nasal bridge with crusts, very important, very typical site. Around the nipples. Now, this is very typical. When you see crusts around the nipples in cats, you must think pemphigus. However, this is not so frequent, it's not so common. And then, very, very important, the foot pads, but most of all, the nail beds. The nail beds with this cheesy cottage cheese, you have cottage cheese here? Yes. Material, it's typical of pemphigus. So let us see the ears. You see different cats with different lesions. Here you have a drop of pus. You have these yellowish crusts inside the ears. This is not the brown crusts due to scratching and dry blood. This is a yellow crust. That is important to recognize. And then we have the nasal bridge. We have lesions on the nose. You can see them here. They are very, very common in pemphigus. And then sometimes you see also crusts around the nipples. This is a nipple on the abdomen. These are two nipples. Sometimes, but I saw this very rarely, you have more widespread lesions on the abdomen, but that is certainly not the most common case. Foot pads, Here you may imagine another pustule and crusts around the footpads. Here you have a pustule. Now if you see this, you may also think of eosinophilic granuloma, eosinophilic plaque, like we saw yesterday, but when you see a pustule, you know this is not a granuloma and a plaque. You see this encrusted pus, and here that is really a giveaway. If you see several nail beds with this cheesy material, then you know this is a pemphigus. If you only see one nail, this could be a bacterial infection of that finger. But if you see several nail beds, you know it's a pemphigus. And that is the reason why when you visit a cat, you have to open up every nail bed and check if they are okay. Now you see this cheesy material, you can pick that up with a toothpick and you can put it on a glass slide and do cytology. And what you will see is, in fact, a lot of neutrophils. You see them here. They are mature neutrophils. They are old. Their nucleus has 4 or 5 pieces. That means that they were given the time to become adult. That means they were not killed before by bacteria. These lesions are usually sterile, so you will not see any bacteria, and you will see these acantholytic keratinocytes. These are cells of the epidermis that have been detached one from the other because the desmosomes, the connections were destroyed, and they can be in rafts, they can be single, they are usually round, they have a cytoplasm that can be lighter in color or darker depending on the level of the cell. It is darker in the deeper cell, it is lighter in the more superficial cells. And here you see many neutrophils with some acantholytic keratinocyte. Okay, now I think you should not rely on cytology to make the diagnosis, because this is a disease where the cat will need immune suppressive therapy for the rest of its life. So you have to be really sure that the cat has pemphigus. You make a biopsy, right? So this is one biopsy. This is the epidermis with the stratum corneum. This is a hair follicle. And in this hair follicle you have a lot of cells, and when we look a little bit closer, we see exactly the same thing that we see in cytology. So we see a lot of neutrophils, and we see these epithelial cells that are detaching. They are swimming in this sea of neutrophils. These are crusts, because what is typical of cats is that they make a lot of crusts, and in this crust you see a lot of neutrophils, but you also see the acantholytic keratinocytes. Now it is a very good idea to take the crust. You just pick them up from the cat and you put them in formalin and you send them to the pathologist together with the skin biopsies. Because many times the diagnosis is made from the crusts. You see here the acantholytic keratinocytes. And so the pathologist will be very happy to receive these crusts, because in there he will make the diagnosis by seeing the acantholytic keratinocytes. And sometimes in some situations where it was not possible to take biopsies because it was not possible to anesthetize the cat, we have done the diagnosis just by picking the crusts and analyzing the crusts, and not a skin biopsy, if that is necessary. Okay. How do we treat these cats? Well, the good news is that we get a remission quite easily. In 93% of the cases, we get a remission within 3 weeks. And of course, we use corticosteroids, and the dose is, the published dose is 2 to 4 milligrams per kilogram. In fact, I don't use such a high dose. I stay on the 2 milligram because I don't think it's really necessary to give a lot of corticosteroids. Remember that we use prednisolone and not prednisone in cats, or methylprednisolone. If they do not respond, you can go to triamcinolone, 0.2 milligrams, or dexamethasone. Okay, you give it for 2-3 weeks, and when you see that the cat has a good remission and there are no new lesions that are coming, then you start decreasing the corticosteroids. And you can decrease by 25% each time, and you want to wait a couple of weeks before you do the next decrease, because when you decrease, you have to check that there are no new lesions coming out and that the old lesions are healing. At one point, you may get to the situation where you have decreased too much with your cortisone and the lesions are coming back. Sometimes this dosage of corticosteroids is very high, so what I like to do is to give something else, and I usually use cyclosporin so that I can decrease the corticosteroids and stop the corticosteroids, and I just keep my cat under control under cyclosporin, which is much healthier than giving corticosteroids every day for the rest of the cat's life. And feline pemphigus responds very well to cyclosporin. I'm going to tell you in just 1 minute. So cyclosporin, remember, the dose is a little bit higher than in dogs. It is 7 milligram per kilogram. As an alternative, you can combine with chlorambucil 0.1 to 0.3 milligram per kilogram. However, as we will see in a minute, chlorambucil is not as effective as cyclosporin. And there have been also some cases that have been treated with tetracycline and niacinamide. So let us talk about cyclosporin, because I think that was a very interesting article. They have compared the efficacy of giving corticosteroids plus cyclosporin to corticosteroids plus chlorambucil. So they started with the steroids at a high dose, and then they tapered the steroids, and they saw that there was no difference in remission time or disease response between these two groups, but the group that was given cyclosporin together the corticosteroids could stop the steroids and just go on only with cyclosporin, while the group that was given chlorambucil, when they tried to stop the steroids, the disease would relapse. So they could never stop the steroids. And that's why I like cyclosporin, also because it is registered for cats, and chlorambucil, you must do a lot of blood work because it can give leukopenia and it's more toxic. Okay, what about oclacitinib? Because as I said yesterday, we are using oclacitinib quite a lot for autoimmune diseases in dogs. Now there are publications of the use of oclacitinib for canine lupus. There are publications of using oclacitinib with pemphigus vulgaris, and there is also one publication of the use of oclacitinib in cats with pemphigus foliaceus. Now this is the publication. This cat could not take any corticosteroids, could not take any cyclosporin because had comorbidities, and so they tried oclacitinib, and he went, you see the lesions on the face, on the paws, he went in nice remission, starting at 1 milligram per kilogram twice daily, and then they could keep it under control with 0.5 milligram per kilogram twice daily. So that is another nice option. If you have not very severe lesions, if you have only mild lesions, you may even think of treating them topically with topical hydrocortisone saponate. This is a case of mine. You see the crusts on the nose and the crust on the ear, and by treating with topical hydrocortisone saponate, you cannot spray a cat like that. He will not like it. So you spray on a cotton wool, and then you just put it on the lesions. Here you see that the lesions on the nose have healed completely, and also the lesions on the ear. Now the hair is not growing back so quickly, I think most probably because of the action of the corticosteroid on the hair follicle. But at least this cat does not have pus and crusts anymore. So there is one publication that mentioned this. However, in this publication, they have used hydrocortisone saponate together with pentoxifillin, while my case that I just showed you, it was just hydrocortisone saponate alone. Okay, now, before we go to the other diseases, I would like to know if you have any question on pemphigus foliaceus. No.
Cyclosporin should be given in the empty stomach, no, madam, in the cats.
Cyclosporin?
Is it to be given in the empty stomach in cats?
In the?
Empty stomach, madam.
Before
Empty
food.
stomach, okay. On empty stomach, I don't think it is really necessary to give it on empty stomach.
Because we give cyclosporin in the dogs in the empty stomach. That is why I asked this question.
Yeah, okay. The point is, they have checked if on an empty stomach or on a full stomach in dogs is the same, and they show that the efficacy is the same. And to be sincere, in dogs, you can have vomit with cyclosporin. And so I tell my owners, if your dog, try to give it on an empty stomach. If it vomits, then try to give it on a full stomach and see if it is better, or vice versa. And I had a dog that the owner has tried systematically all timings, because this dog was vomiting. And when he gave it exactly 3.5 hours after having eaten, that was the only time where the dog was not vomiting. And so what I say is, try. And I guess that in cats it is similar. So you just try, because sometimes they vomit, and you should try to give it when it's better. But yes, it is written on an empty stomach, but in fact it is working anyway. So how many of you have seen pemphigus until now? Okay, in dogs. How many of you have seen pemphigus in cats?
Actually, we have seen even in this workshop.
You have seen in this workshop? Wow.
One cat has come.
One cat.
Yeah,
And
we have done skin biopsy in that.
yes. And the lesions were similar to what I have shown you? Okay. Okay.
Is gingival hyperplasia present in cats also? That cyclosporin?
Yes, we mentioned that yesterday. I have shown a photo. It is not so frequent. I have seen one case, but yes, you can also see it in cats. But it is not the only drug that gives gingival hyperplasia. I'm not expert of other drugs, but I know that there are other drugs that can give gingival hyperplasia. You should talk to dentists, they know this. Okay, so if we are done with pemphigus foliaceus, we can go to the other diseases, but they are not so frequent. Let me do just one thing. Okay. Now we're going to talk about pemphigus vulgaris. And you remember, pemphigus foliaceus has the lesions that are very superficial. Pemphigus vulgaris has the lesions that are quite deep, because the target in dogs, we don't know anything about cats, in dogs is desmoglein 3, which is expressed just above the basal layer of the epidermal, of the epidermis. Here is the basal membrane, and this is just one layer of epidermal cells above the basal membrane. And here you have the cleft. You will also notice that there are no neutrophils here. The lesion is a vesicle. When the vesicle breaks, you have an erosion. So in cats, pemphigus vulgaris is a very, very rare disease. There are only 4 cases that have been described. We cannot make any statistics about 4 cases. The median age of these cats were 1 to 14 years with a median of 5 years. We cannot make any statistics about predisposition. Most probably, the target antigen is similar to that of dogs, because the lesions are very similar. And so the vesicle with a positive Nikolsky sign. What is a Nikolsky sign? When you press on the lesion and you just push, you will see that the epidermis is detaching from the underlying dermis. And that is the Nikolsky sign. That is typical of these diseases. Now, different to pemphigus foliaceus, the target cadherin, desmoglein 3, is expressed not only in the skin, but also in the mouth, in the mucosa. So you will see lesions in the mouth and in the mucosa. While in pemphigus foliaceus, you don't see lesions in the mouth. In pemphigus vulgaris, you see lesions in the mouth. That's a big difference. So you have sialorrhea, halitosis, dysphagia. And these animals, also in dogs, they are feeling bad. Cats with pemphigus foliaceus, usually they feel well. The occasional case has hyperthermia and lethargy, but cats with pemphigus vulgaris, they don't feel very well at all. So these are the published cases, because I do not think that I have ever seen it. In cats, these are the published cases, and you see that the lesions are erosive. So there are pieces of epidermis that have detached from the underlying dermis. Here you see erosions. These are cases from a very nice chapter by Petra Bizikova. Petra Bizikova is the one that has studied these pemphigus diseases in cats, and she has written the chapter on autoimmune skin diseases in our feline dermatology book. So these photos, they come from this book. This is a very nice article that is an open access article that has been published on deep pemphigus in every species, so on pemphigus vulgaris, not only in cats but also in dogs. And these are the few photos that we have from pemphigus vulgaris in cats. You also see erosions here, and you see erosions in the mouth. And these are pretty severe lesions. And the histology, you see that the clefting is deep, just above one layer of cells that remains attached to the underlying dermis. So this is a very deep lesion. And these are other photos. You see that there are cells still attached on the basal membrane, and the whole epidermis is here above. You can see it better. These are still keratinocytes. Here you have the acantholytic cells, and this is a vesicle. There's no pus. It's not a pus. Okay. What do you do with these cats? Well, the same. Immune suppressive drugs like glucocorticoids or other steroid-sparing drugs. Now we are going to very quickly speak a little bit about basement membrane autoimmunity. So this is the keratinocyte cell, this is another cell, this is the dermis, and here you have the basal membrane. Now we know that the keratinocytes are attached to the dermis through the basal membrane with these structures that are called hemidesmosomes. And the hemidesmosome, in fact, is half of a desmosome. So we have inside the cell the plaque, which is attached to the keratin filaments of the exoskeleton. This is the cell membrane. This is the basal membrane. And these are the collagen fibers of the dermis. So this is all very well attached, the cells, to the underlying dermis. And this is quite a complicated area. This is the cell membrane. These are all the molecules of the intercellular plaque. These are the collagen fibers in the dermis, and these are all molecules that are part of the basal membrane. And this is a very simplified scheme. It is much more complicated. Here, it is another scheme. Here you have the cell, the intracellular plaque, the molecules that attach the cell to the basal membrane. And you see here the different names. There are so many molecules, and there are so many targets of the production of autoantibodies. And for this reason, we have many diseases, because we have many targets. But the problem is that it is even more complicated. We have some diseases that have more than one molecule as a target. We have some molecules that are causing, as a target of production of autoantibodies, more than one disease. I don't want you to learn on this. I just want you to show that it is a very complicated matter. Many diseases, many molecules in here. These are the diseases that are recognized in dogs. In fact, in cats, we only recognize two diseases. One is bullous pemphigoid, and the other one is mucous membrane pemphigoid. There are two articles, one each. So this is nothing, just one or two cats for one disease or one or two cats for another disease. In fact, what they have in common is that because these molecules in the basal membrane are destroyed, we have a detachment of the epidermis from the underlying dermis. You see it very well here. You do not have the one layer of epithelial cells on the bottom of the vesicle like you have in pemphigus vulgaris. The whole epidermis is on the top of the vesicle. You see it very well here. Here, it's just only dermis. And what is here stained with immunofluorescence is the deposition of the autoantibodies. So there are targets here that will bind the autoantibodies. This slide was given to me by Thierry Olivry. He is one of the most important dermatologists in the world. And this is a collection of cases that he could have from his colleagues about feline mucocutaneous pemphigus, which most probably is the most frequent form of these diseases, with vesicular diseases of the basal membrane. And again, we have erosions. You see them here in the canthus of the eye. We have erosions here in the lips. We have erosions in the mouth because this is a mucosal disease. So we have lesions in the mucosa. Here you see them here. And the female to male ratio in these 6 cats was 1, so the equal number of males and females. The age was 1 to 8. The average was 4 years. And 2 cats also had some sort of liver problem because they had elevation of ALT. How do we treat them? This is a case that I also had of this basal membrane autoimmunity. You see the erosions. They are close, usually around the eyes or around the mouth, in the oral mucosa. What I did is I used the common protocol of giving corticosteroids and cyclosporin, and I got a good resolution of the lesions. Now this cat is doing well. And so, in fact, the therapy of these cases is always the same. We do not know very much about the etiopathogenesis of these diseases. We think it may be the same as in dogs, but as I said, cats are not small dogs, so there is still a lot of research that has to be done. Okay, and this is to remind you to save for the Boston Congress. Is there any disease? Are you okay, or are you sort of... Because this is difficult diseases, right? Was everything clear? Otherwise, I will repeat it. Clear? Okay.
Ma'am, could you speak a little on eosinophilic granuloma complex in cats?
I have done it yesterday, a whole lecture.
Yeah, but how long? My basic question is, how long can steroids be given safely without affecting the liver?
Okay. I said that yesterday too. You were not here yesterday? You were here, okay. So it is better if you do not use steroids for the whole life. So what I usually do in these cases is to give steroids at a high dose for 2 or 3 weeks, like 1 or 2 milligrams of prednisolone. And then it would be better that you use another drug for long-term maintenance. For example, you can add the cyclosporin from the very first day. So after the 2 or 3 weeks that you have given steroids, you stop the steroids and you continue only with cyclosporin. However, if the owner is not able to pay or to give the cyclosporin and you absolutely need to continue with the steroids, once you have achieved the remission of the lesions, the ideal maintenance dose for the corticosteroids is not more than 0.5 milligram per kilogram every 48 hours. Never every day, every other day would be ideal. And if everything goes well, you can give it twice a week or every 3 days. Okay? No, for the prednisolone, yes. Okay, if you use triamcinolone, the dose is 1/10, so it's not 1 or 2 milligrams in the beginning. It is 0.1, 0.2 milligrams in the beginning, and then you go to 0.05 milligram for the maintenance dose, and for triamcinolone and dexamethasone, the ideal would be once every 3 days. If you give it once every 2 days, it's still too much because these steroids are very, very strong. So once every 3 days is the ideal for dexamethasone and triamcinolone. This is how I do it. I mean, another dermatologist would do it different, but you asked me, and so on. Okay.
Ma'am, for pemphigus vulgaris, you said treatment by glucocorticoids. But is there anything else? Because if the cat is having any other complications, then we cannot use glucocorticoids. So in that case, what to do?
So,
And what will be the dose for glucocorticoids in pemphigus vulgaris?
it is the same as in pemphigus foliaceus. So we go about 2 milligram prednisolone in the beginning phase, 2 to 4, but 4 is high. And if the cat cannot take corticosteroids, you can start with cyclosporin alone, but it will take more time to get the cat under remission. If the cat cannot take even cyclosporin, the alternative we know now could be oclacitinib.
Thank you.
Okay? Any other question? Yes. There is one question still.
Madam, thank you very much for this nice lecture. Particularly the ultrastructural level explanation was very useful for us. My question is, in pemphigus, whatever form it is, we search for the presence of anti-keratinocytic IgG with different substrate immunoreactivity, and the role of different autoantigen targets. So in the practicing level, in your place or anywhere in the world, or in managing or drawing a conclusion, any role of immunohistochemistry comes into the picture?
Well, no. At the practice level, no. Immunohistochemistry or immunofluorescence has no role. We don't do it on a commercial level. We don't do it on a everyday. We don't do it on an everyday working routine. These are just for research purposes.
All right. Thank you.
Okay. Let's talk about the steps in recognition and treatment of lupus and pemphigus in clinical practice. Immunomediated skin disease are diseases where we have an attack of self-antigen. We saw yesterday the immune system was attacking something that was coming from the outside. Today we are going to see the immune system fails to tolerate self-antigens. We can have a primary immunomediated skin disease, and we call this idiopathic when we don't find a trigger factor. We have also secondary immunomediated skin disease, where on the contrary, we can identify the exogenous trigger antigen, for example, drugs, bacteria, or virus. These are very difficult diseases to diagnose on time because they can have a huge range of skin lesions, and sometimes they overlap between them. So sometimes it's hard to find the perfect diagnosis test, and unfortunately we can also have no specific test result, above all if we didn't do the diagnostic workup very, very well. So the most important part is to do the clinical assessment in a perfect way. We have to consider the signalement and the historical feature. For example, breed is very important for autoimmune disease. We know that if we have a German Short-Hair Pointer or a Vizsla, it is probably more easy to have an exfoliative cutaneous lupus erythematosus. If we have Akita, Chocho, Cocker, they can have pemphigus foliaceus, and in cat, Siamese, Persian, and Burmese as well. German Shepherd represent more than the 50% of cases of cutaneous lupus and mucocutaneous lupus erythematosus. And if we have, for example, Shetland and Collis, we will have a vesicular lupus. Also, anamnesis may be important. If you know that the dog is relapsing with exposition to the sun, take in consideration lupus, for example, and also pemphigus erythematosus. It is important to look at the primary lesions, try to understand which is the primary lesion. If it's a pustule, it's an ulceration, which is not primary, so maculae, for example. Look also the distribution. It's just the nose that is involved. It is generalized, and then you should run the test accordingly. Always try to interpret the result in line with the clinical findings. There are many diagnostic tests that you can do when you have an autoimmune disease, but the important thing is do not start, for example, with the anti-nuclear antibody. Start from the basics, so start with the cytology and then go for the biopsy. Hematology and biochemistry are also important prior to treatment. Diagnostic imaging may be also needed to investigate any internal triggering disease. Let's see the cytology. This is very important. It's easy, it's cheap, it's rapid, it's something that you can do. It's money for us. So it is important because it allowed you to differentiate from septic, infection disease, and sterile. Autoimmune disease are sterile diseases. So it is also important that you understand which type of inflammation is present. And for example, here in this picture on the left, you can see that there are many neutrophils and these round dark cells, which are the acantholytic cells. Here in this picture, we don't have any bacteria. On the right, on the contrary, you have neutrophils that are phagocyting bacteria. So we have an autoimmune disease on the left and an infection on the right. This it can also help you because you can, when you take the biopsy, if you saw that there were acantholytic cells without any infection in the cytology, you could even already start the therapy. And also sometimes, maybe the owner doesn't have the possibility to pay for the biopsy and for the histological examination, and so maybe you can skip the biopsy. It's not the ideal, but sometimes we do. Cytology can be obtained in a variety of ways, in different ways. The ideal would be to, if you have an intact pustule, like in the first picture on the left, you will cause a rupture with a needle and then you smear the contents onto a microscopic slide. And otherwise, if you have a crust, you can just rise the crust and then do the apposition with the slide. You can also use a Scotch tape, but it's not the best for autoimmune disease, but it can help you, above all if there are greasy area, it helps you to see if you have infection. Skin biopsy is one of the most important tests that you can do when you have an autoimmune disease. It helps you to rule out the differentials and to confirm your suspicions. it is important to take more than 3 biopsies. As I said yesterday, I'm not gentle. I took all the time 5 at least biopsies. You need to sample the primary lesions and, if it's possible, take different type of lesion that may represent the disease process. If you have a pustule, try to sample entire the pustule, so the whole lesion, and avoid eroded and ulcerated lesion because they are not very helpful. We have a very big range of lesion when we have autoimmune disease, but the most important and common are the primary lesion, as you can see here. Unfortunately, most of the time we have secondary lesions. The secondary lesion, for example, we can have erosion and ulcer, which come from the death of keratinocytes. We have crust, and crusts are very important because we saw also yesterday we can have crusts are the result of the dry exudate on skin surface, and if they are black or reddish, they come from blood, which come from erosion and ulceration. It gives you the idea that the process is deeper in the dermis. And if they are yellow, they come probably from pus, and so the primary lesion was a pustule. So think about what is it and what form it. It's a pustular disease, it's an ulcerative disease. So here the two types of autoimmune disease. On the left you have a dry yellow crust, which are typical of pemphigus, and on the right you have this ulcerating and crusting disease, which is typical of lupus. So let's start with the pustular diseases. So what is a pustule? A pustule is a circumscribed elevation of the skin which contains pus. And pus, most of the time, is formed from the infiltration of neutrophils. Sometimes we can also have eosinophils. Most of the time, these pustules are really transient and they become immediately crust. And when there is also resolution of this crust, you can have a collarettes. So here we have a case. It's a Betty. It's a 7-year female natural Springer Spaniel. She had 10 weeks of non-pruritic progressive crusting dermatosis. He had loss of appetite in the last 3 days. They didn't travel in endemic country for leishmaniasis. So in general she was fine, but she had pyrexia of 40 degrees and mild peripheral lymphnode adenomegaly. So as you can see in the picture, he had a pustule, but they were not so frequent. We had a lot of other and crust. We had the pus and erosions. As you can see here, we have also some erosion. Indeed, in the last period, she was also developing a little bit of pruritus. That's why probably he developed this erosion. The distribution was multifocal. He had on the dorsal part of the nose, around the eyes, also medial pinnae were affected, and also foot pads. So our differential, since this was a pustular dermatitis, we took in consideration all the diseases that can cause this. So bacterial infections such as pyoderma, folliculitis, pemphigus foliaceus, superficial pustular drug reaction, this is very rare disease, superficial pustular dermatophytosis, and leishmaniosis. We said that he didn't travel, so we could rule out leishmaniosis. And if we check to the signalement, this is not very helpful for Betty, but in addition to the fact that he was not traveling, we also know that he didn't receive any drugs in the 2 weeks before the appearance of these lesions. So for this reason, we also rule out the superficial pustular drug reaction. Concerning the lesion distribution, face, skin, and foot pads, there were kind of suspicion of pemphigus. So for us, pemphigus was the most important differential. You know, this is autoimmune disease, bacterial infection, and superficial pustular dermatophytosis, they are not. So the diagnostic workup that we decided to do was first to rule out dermatophytosis and also infection disease. So we performed the trichoscopy, the fungal culture, the PCR. They were all negatives for dermatophytosis. We used the cytology because, as I said, also bacterial infection was one of the differential. So we check the few pustules that were present, and we also check under the crust. So the microscopy show a sterile neutrophilic inflammation and acantholytic keratinocyte, as you can see in this picture, and some eosinophils. This cytology was consistent with the pemphigus foliaceus. As I said, I could also have, once I rule out everything, I could also give already a therapy to this owner. But anyway, is a long-term, is a disease that needs a treatment for the rest of their life most of the time. So it is important to take anyway the biopsy to have a confirmation of this. We also collect the blood sample and also urine analysis we did because before giving the therapy we want to be sure that the animal was healthy. And anyway, we also tested for leishmaniasis because it's true that the dog never traveled, but now the epidemiologic situation changes so easily because we are traveling a lot, so I prefer anyway to do it. And it was negative. The biopsy here is where I would have done the biopsy, so I would have sampled a whole intact pustule and also the crust. We took 3.6, between 3 and 6 biopsy, and we use, this is a quite big dog, so we use a 6 millimeter punch biopsies. The histopathology reveals subcorneal pustular dermatitis. You can see here the formation of the pustule, and inside you can see the acantholytic keratinocytes. Canine pemphigus foliaceus is characterized by autoantibodies, which are mainly IgG, which target components of the desmosome, which normally are helpful to keep the keratinocyte attached. So these junctions are destroyed, and so the cells are detached. And since they do not have the neighbor that keep them steady, they are losing this polygonal form, and they become round. Then, in a second moment, there is an inflammatory response, so neutrophil will come, and then we will have the formation of the pustule. Canine pemphigus foliaceus is a disease of middle-aged dog, but this can anyway happen in any age. We have a predisposed breeds: Akita, Chocho, Cocker Spaniel, Dachshund, Labrador, Bulldog. There is no sex difference, even though I remember there was a study that showed that it's a little bit more in female. The history is important. It can be variable pruritus, most of the time is due to the secondary infection. It can be spontaneous, also drug trigger, And also we have a report about the topical and oral ectoparasitic treatment that cause this. We can have a UV exacerbation and the prognosis is guarded. Most of them, they respond quite well to the therapy, but sometimes, some dogs, they do not. Here are lesions that we can have with the pemphigus. We have pus, we have yellowish crust. They can be on the periocular area and the dorsum of the nose, the inner part of the ears. They can be mild, but we can also have some forms that are more severe, as the next slide that I will show. We can have possible also systemic signs such as depression and fever. This dog is quite more generalized than the previous one. The diagnostic workup is when you have in a predisposed dog with a compatible history and you have the typical clinical signs of pustules and or yellowish crust, you have to perform the cytology. If you see the acantholytic keratinocyte, you need anyway to rule out a superficial pyoderma. If you see that there are bacteria, you give antibiotics for 2 weeks, and then if the lesions are still present, probably they improve, but if they are still present, you will go for the biopsy. Pemphigus erythematosus is a pustular crossing dermatitis, has pemphigus foliaceus, but is limited on the nasal planum. And differently from pemphigus foliaceus, we can have a nasal depigmentation. That's why it's called erythematous. This is interesting because once it was considered a disease that was a mix between pemphigus and lupus, and now we know that there is nothing to do with the lupus. It is occurred in German Shepherd Collie and Shetland Sheepdog, which are predisposed, and it has a waxing and waning course. It is pretty photosensitive, and the diagnosis is similar to pemphigus foliaceus. It can also involve the dorsum of the nose and the planum nasum. As you can see here, in addition to the crust, the yellowish crust, we also have the pigmentation of the nose. Do you remember of Betty? So the standard of care of patients with the pemphigus foliaceus is immunosuppression. So there are many immunosuppressive drugs that we can use in dogs, also in cats. We can use as monotherapy or combined. In the case of Betty, this dog had quite a generalized lesion, so our approach was to give cortisone. We can use prednisone or prednisolone in dog as well. At 1.2 milligram a kilo, you give once daily, and then you taper. I will show you later how we can taper. And I associate azathioprine 1.5, 2.5 milligram a kilo, sorry, I forget milligram, once daily. This is a thiopurine. It's drugs that has a cytotoxic action, and it inhibits the T cell synthesis, and this is commonly used to spare cortisone because we cannot continue with cortisone. And azathioprine, it's a treatment that if you monitor well in the beginning and you find the correct dosage for this dog, then it's pretty well tolerated. But if you have a owner that you are not sure that he will be back for the follow-up, maybe it is not the best treatment to give, because anyway it is associated to side effect. It can cause myelosuppression, you can have anemia, thrombocytopenia, leukopenia, you can have also hepatotoxicity which elevated transaminase and also phosphatase alkaline. So what I do is to do the blood sample before starting the therapy, and then every 2-3 weeks for 3 months, and then every 3 months. Here is an example for a dog like Betty that was weighing 20 kilo, and we gave prednisone 10 milligram pills. As you can see, I gave 2 milligram kilo 1 milligram kilo in the first 10 days. Sometimes I can arrive until 2 weeks, but never more than 2 weeks. And then I start to decreasing the dosage, half of the dosage the second day. So for example, as you can see here, one day I gave 1 milligram, and the other day I gave 0.5 milligram. My idea is to arrive after 1 month to have every other day the treatment, which is, as we said before, is the safe dosage of prednisolone in these animals. And only when I decrease a lot of cortisone, or I be able to stop cortisone even better, I start to taper azathioprine also, and I will start with every other day. And after 1 month, if it's still okay, I can taper every other 2 days. What about the cat? Chiara already told a lot about this disease, but let's see a little bit how is the pemphigus foliaceus in cat. Is the most frequent autoimmune skin disease, is anyway less common than dog. We have IgG antikeratinocyte, and the target of this autoantibody is not still clear. We have this more in European, Semese, Persian, Burmese, Himalayan. The average is between 6 years, but it can also go from 4 months and 16 years. Female are more represented, and we can have a spontaneous drug induction and thymoma associate. I want to show you, this was a case that I had 2 weeks ago. The owner arrived with this dog, cat was a Siberian. That was younger than 1 year, and he developed this pustular dermatitis 7 days after the second vaccine for the feline leukemia. And he presents a lot of these pustules and crust on the inner part of the pinna. The 4 paws were completely full of pustule, and also he had this caseous material around the knees. I gave it 2 weeks of antibiotics. It didn't improve, and so I performed biopsy. And as you can see here, it was a pemphigus foliaceus. As we saw in my case, the distribution of lesion can be around the claws, but it can be also in the nipple, on the nose very often, periocular area, and ears. The prognosis is fair in cats. Here is other example of the lesion in another case. And here are the yellowish crust on the dorsum of nose, and again the severe inflammation around the claws, and also the purulent material that we can have here. Differential in cats are squamous cell carcinoma. I would say this is more often when, since this is also pruritic disease, and if the cat starts really scratching the nose, he can also hurt himself, and so he can mimic the ulceration that we can have with squamous cell carcinoma, as you can see here, and mosquito bite hypersensitivity as well. Nothroidric mange, and erythema multiforme, and eosinophilic plaque. The diagnosis is to rule out parasites because, as I said, Notroides meninge can be a differential cytology, and we will see the acantholytic cells and no bacteria, and histology like in dog. The treatment of pemphigus foliaceus in cat is corticosteroids, but as Chiara said, we have to double dose if compared to dogs, and please use prednisolone instead of prednisone or triamcinolone. We can use prednisolone as monotherapy. I have the impression that in cat we can stop the cortisone. We don't need the combination of therapy more often than dogs. And if you see that you are not able to taper and then to stop the cortisone, of course you can combine therapy. You should always monitor for side effects, even if cats are quite more resistant to cortisone. We can use cyclosporine and chlorambucil as pairing agent. Cyclosporine is safer, and we may have gastrointestinal signs, but more of the time they disappear in the first weeks. Important is to test if the fever and the leukemia in the cats, and be aware that this it may be not the best treatment if the cat is a hunting cat, catch a lot of mice, because if the cat has already toxoplasmosis, it's not a big deal if we give cyclosporine. But if the cat is infected with the toxoplasmosis once he started the therapy, at that point the immunosuppression could cause a clinical and severe, even fatal toxoplasmosis in these animals. Chlorambucil is an alternative. We give a 0.1, 0.2 milligram kilo once daily. This is a drugs that it's called a Leukeran, but unfortunately we have only this 2 milligram tablet. They cannot be divided. So something that we can do is something that our oncologist also suggests that is work very well, is to give every other day. If the weight of your cat, for example, needs just half a dosage, you cannot divide, so you give one full but every other 2 days. Be careful, it gives bone marrow suppressor, so you have to control the blood exam every also 2-3 weeks in the beginning. You know, in cats you cannot give azathioprine, it's toxic in cats. That's why the alternative is chlorambucil. And the same, first you have to taper the cortisone, and then you can start to taper the cyclosporine and chlorambucil every other day. Cyclosporine in dogs, we don't use as a monotherapy during the induction phase. It can be used as a sparing agent together with the cortisone, but the efficacy of cyclosporine is not so good in dogs like it is in cats. So I don't use really as the first drugs for pemphigus. I prefer azathioprine. This is a case, so sometimes our cats, they have other comorbidity, and so we cannot use a cortisone. So what can we do? This is a case report where this cat had the FIP infection, and they use this protocol with the pentoxifylline topical hydrocortisone. They also supplemented, it's not written in the title, but I remember they supplemented with the fatty acid, and they had after 2 weeks an improvement of the clinical signs. Honestly, yes, the lesions were not so severe, so it may be a good protocol if you have very mild lesions. As Chiara also already showed, we have also the possibility to give oclacitinib. It was effective in this cat. Also, this cat had comorbidity. He had a chronic kidney and cardiac disease, and they gave 1 milligram kilo twice daily. After 7 days, he had 50% of the improvement, and then over time they decreased to 1 daily. They tried to stop it, but the cat relapsed, so they will start again. Let's see now the other type of lesion that we can have with an autoimmune skin disease. We can have a hypopigment or erythematous macular patches, and more often we can see erosion ulceration. So there are plenty of sterile immunomediated disease and non-immunomediated disease. So today we are talking about the immunomediated disease, and in particular about cutaneous lupus erythematosus and mucocutaneous pyoderma. So cutaneous lupus erythematosus is an umbrella name. It gathers a lot of different disease with different also clinical manifestation, but they are sharing the same autoimmune process. There are different variants. We can divide them based on the onset. If it's rapid, we have the vesicular cutaneous lupus erythematosus, very rare condition, we will see later. And if it's chronic, is the fascial discoid lupus erythematosus, the generalized discoid lupus erythematosus, mucocutaneous, and exfoliative cutaneous lupus erythematosus. There is this nice review. It's very important that you have a look of this. It will summarize very well all this disease. So let's see what caused this cutaneous lupus erythematosus is autoimmune disease. This means that, as we said, there are autoantibody production against the skin. So the exact etiology is unknown, but there are so many proposed mechanisms that have been suggested, but mostly are unproven in dogs. We have a genetic association, the role of infection, drugs, and also environmental triggers such as the sun exposure. So the immune system will attack the keratinocyte, and it will induce the death of them. Here in the histopathology we can see these pinkish dots that are the keratinocytes that are dead. And as a result, we have the formation of this lesion. Vesicular cutaneous lupus erythematosus is a rare disease. The onset, as we said, is very quick, and we have mainly Shetland dog and collie, so they are very overrepresented, and that's why we think there is a genetic predisposition. It's a middle-aged disease. We have erythema and we have a flaccid vesicle. These are also transient. We can have erosion ulceration. They have a very special form. They can be annular, polycyclic, and serpiginous pattern. There are normally no systemic signs and also no abnormal hematology. We have mainly in the abdomen, axilla, groin, and medial thighs as well, and then we can also have a mucocutaneous junction in the rear oral cavity. Here you can appreciate the polycyclic aspect of these lesions. Differential is the erythemal multiforme, as you can see in the picture on the right. It's pretty similar. Therapy is they can be aggravated by the sun, so try to protect as better as you can. The treatment is more or less the same with autoimmune disease, so we give prednisolone 2 mg/kg And then we can taper, we can associate azathioprine, cyclosporin, tacrolimus, and in this review that I show you, calcineurin inhibitor may be the drug that is considered the first choice for treating this condition. We can also use a mycophenolate mofetil, and which is another drug I will explain you later for another disease. Exfoliative cutaneous lupus erythematosus is a disease that is hereditary, is autosomal recessive, familial, and is typical of a young animal. These are young and typical of German Shepherd, Pointer, and Vizsla. Lesions that we have are, we can have scales, alopecia, follicular cast and crust. These are more on the muzzle, pinna, dorsal trunk, and then can be also in the lips, sternum, ventral abdomen. There is a mild pruritus, and this is associated with the side effects, with the systemic signs. For example, they have pain in working, they may have infertility, lymphadenopathy, mild anemia, and they can have also thrombocytopenia. Here is an example of the lesion. You can also see alopecia, hyperpigmented patches. The differential are sebaceous adenitis, as you can see here in the first picture, leishmaniosis, and also cornification disorder. I have this dog with a very important cornification. It was generalized cornification disorder. It was also very young, so it is important because they can also happen very young dogs. Therapy, some benefit of dietary changes, supplementation with fatty acid, anti-seborrheic shampoo, antibiotics, and oral retinoid. In most cases, in a recent case series, they show that the immunotherapy that are normally prescribed either has a single or like combination therapy, tetracycline, niacinamide, doxycycline, oral glucocorticoids, azathioprine, cyclosporin, they were not so really effective. And hydroxychloroquine, which is an anti-malarial drug, it's used with for cutaneous lupus in human. It seems to be a little bit helpful in this condition, at least slow down the clinical progression. Unfortunately, most of the time, since this is not really improving with the treatment and is a progressive disease, most of the time the owner asks for euthanasia. This is the article that explained that showed that this therapy was also useful for the canine discoid lupus erythematosus. I said that I would have talked about mofetil mycophenolate. I work very close with a very good internist, and it seemed to be her favorite immunosuppressive drugs. We don't use a lot in dermatology. Mycophenolate mofetil is a cytotoxic antimetabolite agent. It's pretty expensive, and it's used in canine pemphigus foliaceus. It's used also for exfoliative cutaneous lupus erythematosus. It inhibits T cell activation. Used often in combination with the cortisone as a sparing agent. You start with 10 mg kilo every 8 hours, so even the 3 times per day administration is not the best for our patients. It is pretty safe if we compare with azathioprine or chlorambucil, but the only problem is can cause gastrointestinal disease, but they are not so often actually. It can give diarrhea, hematochezia, vomiting, papilloma formation, but as you can see, it doesn't cause hepatotoxicity and bone marrow suppression. So, for example, I have a dog with a pemphigus foliaceus that had a very high sensitivity against cortisone. So I was not able to give 10 days of cortisone without a hepatopathy. So that's why in this dog I use mofetil mecophenolate. Mucocutaneous lupus erythematosus is overexpressed in German Shepherd, female more than male, middle-age disease. We have a lesion on the mucocutaneous area, so we can have around the anus, genitalia, perigenitalia region, lips around the eyes, nasal planum, and also oral lesion. It seems hurting the animal. Sometimes they show pain, above all when this disease is interesting the perianal area. Most of the time we have more than 2 sites that are affected. Differential mucocutaneous pyoderma, pemphigoid mucous membrane, erythema multiforme. So please give the antibiotics and see the response. Mucocutaneous pyoderma improve after 2 weeks. Generalized discoid lupus erythematosus is rare. You have annular to polycyclic plaque. You have dyspigmentation, so means that you can have both the pigmentation and hyperpigmentation. You can have erythema, adherent scaling, follicular clusters with the central alopecia. You can have this reticulate aspect, net-like that you can see here. You can have a severe hyperpigmentation also in the ventrum. There are no systemic signs. This is the generalized discoid lupus erythematosus, is not the systemic, and the pruritus quite often is in 40% of our animals. This is a case that I had. It had this lesion. As you can see, we have polycyclic lesions that are hyperpigmented. Fascial discoid lupus erythematosus, it's a very benign type of lupus. You have the loss of cobblestone surface of nasal planum, as we can see yesterday. And as you can see, there is edema in the tissue, and you will lose the architectural structure. We can have also formation of the some erosion and ulcer and crust. We have hyperpigmented macular patches, erosion, ulcer crusting, and as you can see in this dog, the skin tends to become blue, also to pink, caused by pigmentary changes. Here's another case. This had just the periocular area that was involved, and the fascial discoid lupus can also be. I'm sorry, but they didn't put a 0 actually. So we had severe crusting in this case, severe ulceration and crusting. And for example, if I have to biopsy, I would do here when we have the passage between the the presence of pigment and loss of pigment. Differential are epitheliotropic T-cell lymphoma, as in the first picture, mucocutaneous pyoderma, and uveidermatological syndrome. We didn't talk about this is a condition where we have also the attack of the eyes. Cutaneous lesion associated with the systemic lupus erythematosus. So it's uncommon. We can have a non-erosive polyarthritis, painful. So the systemic lupus erythematosus is a condition that is not just on the skin, it affects also the organs. So we have non-erosive polyarthritis, painful muscle, and they have pain when they are walking. You can have proteinuria, you can have a problem in the blood cells, they have a fever, they can have lymphadenopathies, splenomegaly, and rarely they can also have pericarditis, pleuritis, and also problem to the central nervous system. The skin lesions are in 33 and 60% of cases, and they can be scaly, mucocutaneous ulceration, and foot path ulcer, hyperkeratosis, sometimes panicolitis. The diagnosis is with, for sure, the clinic, and you need to perform also blood tests. It's a common sense that the diagnosis it has to be done with a combination of a positive ANA test with at least 2 significant signs. Recently, this has been a little bit changed that you need 4 or more criteria, and if the dog has not the ANA test positive, or 3 criteria and a positive ANA test. These criteria are listed here, but I will show you a case that I had. This dog first was referred to the orthopedist because he had really a lot of pain walking, and they diagnosed non-infective arthritis. So since the orthopedist saw that the dog had also clinical signs, he referred to me. So as you can see here, he had alopecia. This is not really easy to see, but the dog had a lot of hyperkeratosis and crust around the eyes. Here he had also the same lesion on the elbow, and then he had this hyperkeratosis and alopecia on the center of the parietal area. Here the other details, as you can see, there were these lesions. The ears were pretty thicker with this hyperkeratotic plaque. And then we had also ulceration, like the same that we can have with vasculitis. So my main differential was leishmaniasis. This really looked like leishmaniasis, so I think I performed 10,000 of time the test and different type of tests, but was all the time negative. Then I tried to see if this dog had all the criteria or part of the criteria that were needed to do a diagnosis of systemic lupus, and indeed he had a facial dermatitis, he had a non-erosive arthritis, he had a renal disorder, he has a persistent proteinuria, he also experienced a few times a seizure, and he had an hemolytic anemia. And it's true, we didn't have an ANA test positive, but we had a compatible histology with the cell-poor interface dermatitis, which is typical of this condition. And what was more interesting, that every time that we tried to pass from everyday cortisone to every other day, the day that he was not receiving the cortisone, he had more than 40 degrees of fever. The management is, if you find a drug that has been caused this, try to discontinue, avoid sun exposition, and try to find internal disease, including infection. Sometimes even the dietary changes can help. do the cytology to be sure that there is not an infection. If there is an infection, treat it, and then all the time take blood before and after starting the drugs. The drugs are the immunotherapy, and these are long-term therapy. How can we treat cutaneous lupus disease? This is depend if you have a localized or generalized form. If it's mild, if it's severe, if it's in an area that is easy to treat. So, for example, if you have a very localized form that, for example, interests only the dorsum of the nose, you can use even just steroid creams. You can use, I don't know what I wrote there, but it was betamethasone 0.1% or fluocinolone 0.1%, or even the hydrocortisone here in this area. And then you taper at the minimum dosage and frequency that is help you to keep under control the clinical signs. Just please ask to the owner to apply the gloves. It's true that probably they will not absorb a lot, but it's better to protect the owner as well. The side effect of applying steroid creams is that they can thin the skin, and if you use a very powerful cortisone, if you use every day, you can also have internal side effects. If you have mild discoidal lupus erythematosus or pemphigus erythematosus with a localized form, you can also use tacrolimus cream. This has been proven to have the same efficacy like corticosteroids. There is no side effect. It may be hurt in the beginning, above all if there are ulceration. You can apply 2 times per day, and then you taper following the response. Also this one with gloves, please, and is expensive. This is a study that showed that 0.03% of tacrolimus ointment was efficient as a monotherapy to treat discoidal lupus erythematosus in dog. But if lesions are more severe, you can use a short course of oral cortisone to help the lesion to disappear, and then you keep the maintenance with the topical glucocorticoids and tacrolimus 0.1%. Of course, if you have generalized condition, it may be better to use oral treatment. In Switzerland, we don't use tetracycline and niacinamide anymore because of risk of resistance, bacterial resistance. So we prefer to use in the beginning or corticosteroids alone, and then combine with other drugs such as is in the list: cyclosporin, pentoxifilin, clacitinib, mofetil mycophenolate, hydroxychloroquine, and immunoglobulins. So here a case which case series where showed that clacitinib is indeed also an option for dogs with cutaneous lupus, and we use 0.51 milligram once or twice daily, and then they have a good remission in 2 weeks, and then you can taper. Thank you very much. If you have any question, please ask me. But we are running out of the time, so.
So, if no questions, we'll go for a break for a tea, coffee, and you will be back here 1 minute.
Okay, so we start again with a collection of feline diseases that are immune mediated, but we don't really know the pathogenesis of these diseases. They are sometimes, this is not, yes, now it's working. Sometimes they are unique to cats, they are very strange, and I have selected some of the most important immune-mediated diseases. So we start with feline exfoliative dermatitis. I do not know if anybody has seen this. It is something it's in adult old cats. And it comes in adult older cats because this is most of the times associated to a tumor. And so only adult and old cats have tumors. And the tumor is the thymoma, which is usually a benign tumor of the thymus. However, we will see later that some cats don't have a thymoma, so we don't understand what's happening. But for those that have a thymoma, this is considered a paraneoplastic syndrome. And because of a thymoma, and you know the thymus is the organ of the body that regulates tolerance towards self-antigens. When you have a tumor there, then you may have autoimmunity because there is a problem in the tolerance of the self-antigens. And so you may develop other signs like myasthenia gravis, polymyositis, or myocarditis. So it is called exfoliative dermatitis because it has a lot of exfoliation. So we have scales. But not only scales, we have erythema. These scales in the beginning are small and then become bigger and bigger. In the beginning they come on the head and then they will generalize to the whole body. We not only have scales, we also have hypertrichosis, alopecia, the hair is easily epilated. And because these cats have a severe underlying disease, because they have a tumor, you remember yesterday we said that cats with a systemic disease may develop malassezia. Some of these cats may develop malassezia infection. Usually this disease is not pruritic, but when they develop malassezia, then with the infection they have pruritus, and then it becomes pruritic. So let us see some images. These are cats that start with a diffuse erythema, sometimes patchy. You also can appreciate that there is hypertrichosis, there is some hair that is lost, and then they develop a lot of scales. I mean, you cannot miss these scales. They are very, very prominent. Look at these, lots of scales. These are just only scales covering the whole body of the cat. Lots and lots and lots of scales. So maybe the only differential would be a very, very severe form of dermatophytosis. But otherwise, this picture is really distinctive. Hypertrichosis, here between the hairs, there are lots and lots of scales. And the scales are big, they are dry, they are attached to the skin, attached to the body, and this is the worst case I have ever seen. Horrible case, full of scales. That is the case of a colleague. So when we do a skin biopsy, we can diagnose this disease. Because in the skin biopsy, we will see the scales, a lot of hyperkeratosis, but we will also see something that is typical of this disease, and that is the inflammation in the epidermis. Here we have a lot of scales, and this is what we see macroscopically. This is the epidermis, this is the dermis, and there is a lot of inflammatory cells around here. When we look closer, these inflammatory cells are small lymphocytes, and they also will cause the death of the keratinocytes in the epidermis. This is called apoptosis, single-cell necrosis, a lot of inflammatory cells here in the dermo-epidermal interface. Now this is exactly the same thing that you would see in lupus. So this is a sort of an autoimmune reaction. I tell my students, when you see lupus with scales in a cat, that is a exfoliative dermatitis of cats. This will also include the hair follicles. They also have a lot of inflammation, so that the hair follicles will not produce hair anymore. And this is where you see the hypertrichosis and the alopecia. How do we treat this? Well, if we have a thymoma and it is a benign tumor, the best option is to remove the thymoma surgically. So here with radiography, you can see that there is something in front of the heart. I think maybe here, I'm not a good radiologist, but you may be better radiologist than me. There is a mass in front of the heart, that is the thymoma. And here they have taken it out. And once you take it out, this is the cat before the surgery with a lot of scales and alopecia, and after the surgery. And you see the cat is back to normal. So the therapy is the surgical resection of the thymoma. Now, why do cats develop this strange lupus-like paraneoplastic syndrome? Well, it may be that there is a sort of an autoimmunity against the epidermis, like we have in lupus, because, as I said before, we have a disease in the thymus, and the thymus regulates tolerance, suppresses autoimmunity, but if you have a disease in the thymus, this autoimmunity is not suppressed anymore, and you can get an autoimmune reaction that looks like lupus. So there is an imbalance of mechanisms of self-tolerance that usually is modulated by the thymus. This is a hypothesis, we don't know. But the problem is that we do know that we can have exactly the same disease without a thymoma. Now is the problem, why do these cats get this exfoliative dermatitis? We don't understand. This is a nice description of 18 cats that had this exfoliative dermatitis without thymoma. Now, 12 of these had systemic signs, so there was another disease, but they could not understand well what was the problem. Of those 12 that had systemic signs, 4 had systemic alterations, but that were vague, were not typical of any disease, like hepatomegaly, splenomegaly, lymphadenopathy. 1 had pancreatitis. Now, of these 18 cats, 12 were treated with immunosuppressive therapy because the pattern in the histopathology was the same as lupus, and so they said, let's treat it like a lupus. And so they treated with immunosuppressive therapy. And they used methylprednisolone, prednisolone, cyclosporin. I would use cyclosporin because this is a lymphocytic disease. Cyclosporin is particularly good for lymphocytic diseases. And these 12 that were treated, they were improving. So if you have such a case where you don't have a thymoma, you can use cyclosporin, and 1 underwent spontaneous remission. Okay. Anybody saw this disease until now? In cats? No? Now we're going to talk about erythema multiforme and toxic epidermal necrolysis. And this is Stevens-Johnson syndrome. Now this is a complex of diseases that are characterized by the death of the cells of the epidermis. And it can be associated with triggers that will cause the death of the cells of the epidermis. For example, viruses. If there are viruses that infect the epidermis, the immune system will recognize that a keratinocyte is infected with the virus, and the immune system will kill this keratinocyte. So this is a way of defending the body. The cells that are infected are killed by the immune system. So, in fact, sometimes the immune system may exaggerate and can cause too much killing, and that can be a disease. And this disease is triggered by viral infections. The same can happen when there is a tumor. The immune system will recognize the tumor cells and will kill them. But sometimes the immune system will kill too many cells, and then we have a problem. Now, why do we have a complex? We have a complex because this is a spectrum of severity from milder form, which is the erythema multiforme minor, to the more severe form, that is the toxic epidermal necrolysis. So we have erythema multiforme minor, which is the milder form. then we have major, then we have Stevens-Johnson syndrome, and the worst one is the toxic epidermal necrolysis. Now, the minor has no systemic signs and no mucosa involved, and has round macules, round patches of erythema as lesion. The major has the same lesions, but has systemic signs. The cats are feeling worse, they are feeling depressed, they have a fever, they don't eat, and they have involvement of the mucous membranes. So I told you that these are round lesions. You can see them here, round lesions. They are actually called target lesions, like targets, you know, when you want to shoot, you have a target. And in the center of these lesions, there may be some scaling, some crusting, and after a while you have erosion in the center of the lesion. And these lesions are also confluent so that they can cause these serpiginous shapes. With time, as I said, they will erode, and so you will have these erosive, round to confluent lesions. Now, it is not easy to diagnose an erythema multiforme just by looking at the lesions. You must do a biopsy. And in fact, when you do a biopsy, this is the epidermis, this is the dermis, this is the basal membrane. You see these red spots here? These are all cells that have been killed. They are called apoptotic cells. They have been killed, and if so many cells die, you see them here, the epidermis will detach, because if the cells die, they will not be able to keep the epidermis together. And that is why we get erosions in these cases. So apoptosis is the most important feature in these cases. So I would like to talk a little bit more in depth about the mechanism of apoptosis. So, for example, in humans, erythema multiforme is really well associated with a viral infection. So let us think that the keratinocyte of the epidermis is infected. In cats, we may think of herpes, because that is what has been associated with erythema multiforme. So there is the virus in the epithelial cell, and the virus will probably show some antigens on the surface of these epithelial cells. The lymphocyte will recognize that the cell has viruses, and the lymphocyte will give a message to the cell that this cell should commit suicide. So in this case, the cell will die. Now, in fact, this has been proven in cats with herpes infection. There are two cases. This is one, and this is another case where these cats had erythema multiforme. They were treated with antiviral drugs, and the cats improved. So here, 3 days of famciclovir, which is the antiviral drug against herpes, and after 3 days, this cat was feeling much, much better. So in cats particularly, when we see erythema multiforme, we should think of viral infection. In dogs, it's not the case. In humans, it is the case. In cats, it is the case. Now, this was the milder form of this. We go now to the more severe form. We go to the Stevens-Johnson syndrome, toxic epidermal necrolysis. Now here, it is not the single cells that die that commit suicide, but it is a massive death of cells, a full thickness necrosis. So in Stevens-Johnson syndrome, about 10% of the body area is sloughing, and in toxic epidermal necrolysis, about 30% of the body area is sloughing. Just imagine that you have lost your epidermis on 30% of your body. It is a like third-degree burn. You have lots of problems because there is a lot of infection, and also there is a loss of water through the skin. The epidermis is an important protection. Just imagine that 30% of your body has no epidermis anymore. This is a life-threatening condition. So these animals should immediately go into intensive care. They should receive systemic antibiotics. They should receive infusion. They should really be checked because half of them will die. So severe systemic signs, lethargy, anorexia. You may have necrosis maybe of other epithelia, not just the skin. You may have necrosis of the respiratory mucosa, of the gastrointestinal mucosa. This is a very severe condition. You remember the Nikolsky sign? The epidermis is just going away like that. Horrible thing. This most frequently is drug-induced, not viral-induced, but drug-induced. This is one of the few cases that have been published in a cat, and that was published by Silvia Colombo, the co-author of the feline dermatology book, my good friend and partner. And here you see that there is erosions and the epidermis is just slapped away. There is detachment of the epidermis. And that was a consequence of giving cefadroxil, a first-generation cephalosporin antibiotic, to a cat. And that was the histology. You see that there is complete loss of the epidermis. There is a bit of apoptosis. There is a lot of damage to the epidermis. Here the cells are completely dead, and so that is the problem. Here you see it better. These cells, they are all dead, and you see that the epidermis is just like boils, just like completely destroyed. Here also, they are all dead, and the epidermis just is not existent anymore. Okay, anybody saw this condition? In cats, that's very rare. Maybe in dogs you have seen it. In dogs, yes. Okay. I'm sure that you have seen sebaceous adenitis in dogs. Yes. And in cats. Let us talk about sebaceous adenitis in cats. So the disease is the same as in dogs. So it's not very different. We have an inflammation that is centered on the sebaceous glands. And we have thus the accumulation of what we call follicular casts. They are plugs of scales that will accumulate in the hair infundibulum. Now the sebaceous glands produces sebum, and sebum is like a conditioner for the hair, so that the hair comes out nice, glossy, lubricated. But if you don't have the lubricant anymore, then the hair cannot grow well, and there will be accumulation of keratin in the infundibulum because there is not a lubricant that helps going out this keratin. So we have these plugs of keratin. And also the problem is that the very small hair, the secondary hair, the wool, it cannot get out of the hair follicle because there is this plug. There is this cork, let's say, in the hair follicle. And so we have hypotrichosis because the secondary hair cannot get out. And you see, this is not an alopecia, but this wool hair, the secondary hair, is missing. Here we only have the strong primary hair that makes it out of the hair follicle, hypotrichosis, and here also this is a hypotrichotic hair. Now when we look better, we can appreciate that at the basis of this hair, there is this accumulation of keratin, these keratin plugs, very similar to what we see in dogs, although a little bit smaller because hairs are smaller in cat. But what is really, really typical of sebaceous adenitis of cats is that they also have an accumulation of crusts around the eyes. You see, this cat seems that he has put kajal, he has put makeup on his eyes, and here you see also the crust, and here you see some crusting around the eye, because there are very big sebaceous glands around the eyes. They are called meibomian glands, and they can also have problems. So I found this very typical of sebaceous adenitis in cats. So the diagnosis is histological. This is a hair. This is a hair follicle. This was a sebaceous gland. We don't have the gland anymore. It's just full of inflammatory cells. So the gland is completely destroyed. I told you that I like cyclosporin in these diseases, particularly if there are lymphocytes, and cyclosporin works very well for this sebaceous adenitis in cats. So we have published the first cases treated with cyclosporin, but recently there was a case that was just treated with those topical fatty acids products that you also have in the exhibition. So these topical fatty acids drops, they can add the sebum that is lacking because the cat is not producing it anymore. So if you don't want to use cyclosporin, you may want to try the topical fatty acids. Well, I usually use cyclosporin, and this is my cat that I published. Here you see the eyes that have these crusts around. After 30 days, it's much better. There's only a little bit of crusts here. And after 60 days of cyclosporin, the cat is perfectly normal. And that is another one. Before, you see the crusts here, and after, you see the hypertrichosis. The coat is not full. The undercoat is missing. And here you have a nice full coat. Okay. So anybody saw sebaceous adenitis in cats? In dogs? Hands up? Okay. Now the next disease that is unique to the cats, dogs don't have this, is plasmacellular pododermatitis. So do you know what marshmallows are? You have them? Okay. Because in Italy we don't call them marshmallows. So I think that you diagnose this disease when you see that the footpads, they look like marshmallows. Because they are soft like marshmallows and they are round like marshmallows. They lose this nice heart shape that they have. They become like small, soft balls. And that is not only one footpad, that is actually happening in more footpads. And usually it is the big footpad. I have seen some cases where there was also some problems with the small footpads, but usually it is the big one. So one big, soft, round footpad, or more than one, you think of plasmacellular pododermatitis. You see, these are those two footpads that are round and soft to the touch. Sometimes the disease gets even worse. You see that in this case there is this violet color because of the congestion, and here you also see that there is an erosion and an ulceration, and sometimes from this ulceration you have the whole tissue of the footpads that gets out like a herniation. Now, when it gets to this point, the best therapy usually is the surgical removal. However, I have heard of some colleagues that treated this conservatively with bandages and with cicatrice gels that were favoring cicatrization and epithelial migration, and they could get the whole epithelium to grow back by second intention and cover again the whole lesion. But it takes time. You have to be very patient. So this is an easy diagnosis. I don't think that you have to make any further diagnostic procedures, but if you want, you can make cytology. The problem is that you get a lot of blood. So all these green things are red blood cells. This is very hemodiluted, and this is a Giemsa stain. And here you may see some lymphocytes and some plasma cells. But it is usually very hemodiluted. So if you want to do a histology, the picture is very, very typical. Now this is the horny layer. This is the epidermis of the footpad. It is very thick, but that is normal in the footpad. The epidermis is always very thick. And look at the dermis. We should have adipose tissue and acrine glands in the footpad, but you don't have anything of that. You only have a lot of inflammatory cells. And you see these are brown cells, and when you look well, you may even find these cells that are full with antibodies. So these are plasma cells that are very much stimulated. We don't know why. and they are producing a lot of antibodies. In fact, there is a hypergammaglobulinemia because they produce so many antibodies, and sometimes it may be so severe that it will give glomerulonephritis or amyloidosis. There may be a thrombocytopenia, we don't know why, and these cats may be more frequently than healthy cats FIV positive. Now, this does not mean that every cat with plasma cellular pododermatitis is FIV positive, but they are more frequently FIV positive rather than the normal healthy cats. So there is a predisposition. You see 16 out of 26 in one article and 4 out of 9 in another article. Usually they are FELV negative. So what is the therapy? Well, we can try to decrease this inflammation with prednisolone, surgery, particularly when we have this ulceration. Here you have the surgery, and cats, they can walk very well even if they don't have this adipose tissue anymore in the foot pads. But the classical therapy that has been used is doxycycline. Doxycycline is an antibiotic, but it also has immunomodulating properties. However, this doxycycline therapy should be for a very long period of time or for the whole life of the animal, because if you stop it, you may get a relapse. And now every guideline regarding the use of antibiotics states that we should not use antibiotics unless there is an infection. And we should not use antibiotics for extended period of times, because this is the best way to cause bacterial resistance. And bacterial resistance is a very important problem, and in the future it will be even more of a problem because there are not many new antibiotics that have been developed. And I'm talking about human health. They state that there will be many dead people in the future because of bacterial resistance. So we should not do that. So the alternative in this case, I think, would be to give cyclosporine again, which has an anecdotal efficacy. We don't have publications, but this is what I'm using now. I try to avoid the use of antibiotics as much as possible. And here, oclacitinib with a question mark. Why not? We may try it. So the next plasma cell pododermatitis that we have, we may try oclacitinib. So what is the origin of this disease? Now, there is a lot of plasma cells. They produce a lot of antibodies. Maybe there is an infectious agent in the foot pad. So these infectious agents have been searched for by different investigators, and they found FIV viruses in some of these lesions. In one, they have found a FELV virus. They have checked all the microorganisms that would respond to doxycycline, because we know that doxycycline is helping this disease. For example, Bartonella, Ehrlichia, Anaplasma, Chlamydiophila, Mycoplasma, Toxoplasma, and herpes virus, but they could not find any of these microorganisms by PCR in these lesions. So we are still not very sure about what's happening with these foot pads. Why are they reacting so much with plasma cells? I don't know. Now, the curious thing is that not only foot pads, but also nasal swellings have been seen associated with plasma cellular pododermatitis. So we have cats that had not only plasma cellular pododermatitis, but also nasal swelling. And some cats had only nasal swellings, but not plasma cellular pododermatitis. And these are some cats from these articles. When you do a biopsy from this area, you see the same picture as the plasma cellular pododermatitis. So this is a plasma cellular nasal swelling. And why is that? We don't know, but that is pretty curious. Okay, so you have seen plasma cellular pododermatitis. Who has seen plasmacellular pododermatitis? I see some hands going up. Okay. There is another condition that is unique to the cat, which is the necrotizing proliferative otitis externa. Now, this is seen usually in cats that are younger than 1 year of age. However, recently there has been other older cats described. So this is not unique to kittens, although it is seen mostly in kittens. And it is a crust and an ulceration in the entrance of the ear canal. So you can see it because these cats start to scratch, start to have problems with their ears. You may think that they have otodectus because you see lots of black crusts, but these crusts in fact are just dry blood because of the ulceration. They don't have otodectus. These cats are negative for any viral disease. So when you see this, you think of otodectus, right? But then you check well, and what you see is that there is a well-demarcated lesion. You can see it here. And this lesion is hyperplastic. It is like a lot of proliferation of the epidermis. It's not smooth, but it is hyperplastic. You see it very well here. And it is at the entrance of the ear. And it is ulcerated, crusty, and well demarcated. Now, when you clean this from the crusts, you can see that it is well demarcated, very inflamed, and ulcerated and hyperplastic. So this is certainly not an ear mite otitis. But sometimes these lesions can be seen also in other areas of the body. This was a couple of articles where they saw the same hyperplastic, ulcerated, crusty lesion on the mouth or around the eyes, but also in the perianal skin. Or they may be not limited to the entrance of the ear, but they also can involve the ear canal. And that was another case that was also published by Silvia Colombo, the co-editor of our feline dermatology book, where they saw this hyperplasia also in the vertical and horizontal ear canal, but not in the pinna. So what happens here? This is a biopsy. So this is the cartilage of the ear canal. And here you have the hyperplasia. You see this irregular, it's like some digits of the epidermis. This is really a lot of hyperplasia. And you see the crusts here, this is a crust. And when we look better, we see that there is a lot of inflammation, lots of neutrophils, lots of lymphocytes, lots of crusts. It's really a lot of inflammation. And here we also have these apoptotic cells. Again, an immune-mediated disease. Like we saw in erythema multiforme, these are cells that are committing suicide. Here you see the lymphocyte that is telling to the keratinocyte, you should commit suicide. This is called satellitosis. Why is this happening? No idea. We really do not know what happens here. You see the satellite, the lymphocyte, and the suicidal keratinocyte, the apoptotic cell. But because we have apoptosis, and this is an immune-mediated mechanism, we can use immune suppressor to treat this disease. And because this is a very small area of the body, just a couple of square centimeters, we try to use topical therapy. So what has been tried is like very potent corticosteroids topically, or tacrolimus. You remember that when there is an immune-mediated disease, I like to use cyclosporine. Cyclosporine is a calcineurin inhibitor. But cyclosporine is not going to work topically because it is a molecule that is very, very big, will not be able to pass through the epidermis. Well, tacrolimus is also a calcineurin inhibitor, but is able to pass through the epidermis. And so tacrolimus is my topical cyclosporine, let's say, and is working very well. So this is what we usually use. You have it for animals We are not so lucky to have it for animals. We have it for humans, very difficult to get. But that is what we use. And there is also one article that we're using oral corticosteroids. Now this is before the treatment, and this is after the treatment, after 2 months. You see, the lesion has gone away very well. You treat for a couple of months, for 3 months, and then you stop the treatment, and usually the problem does not come back. Okay, was this enough? Well, there are other immune-mediated diseases of cats, but they are so rare that only 1 or 2 cases have been described, like pseudopelade or so, and I don't think it would be a long list. So, any questions? Any experience with these diseases? Okay. You have a lot in dogs. My cats are different.
They are delegates.
Okay, thank you. So let's start with the inflammatory alopecia. Let us begin with the classification of alopecia, which can be congenital, and therefore it means that it is present from birth. There are some breeds that are born alopecic, like the Chinese crested dog. Some individuals of breed that normally are with hair, they can present hair loss, and they can be born with the ectodermal defect. So we have an alopecia phenotype, which is often associated also to problem in their teeth. We then know also acquired alopecia, and these appear after birth, and these are animals that are genetically normal, and then after the birth they start losing hair. This can be inflammatory and non-inflammatory. Alopecia can be also classified in spontaneous and self-induced. Spontaneous, there is not animal involvement, and the self-induced is the animal that removes the hair. The topic of today is the spontaneous alopecia. When spontaneous alopecia can be inflammatory and non-inflammatory. We talk about inflammatory when we have an inflammatory infiltrate that causes problem into the hair follicle. Non-inflammatory is we consider the disease that they have hair growth cycle disruption or abnormal formation of the hair. Today we will talk about the non-inflammatory, and there is a long list of non-inflammatory alopecia that will be explained during this presentation. These are diseases that they can may resemble each other because we can have partial or generalized hypotrichosis, and normally we don't have pruritus, we don't have erythema, they are non-inflammatory. And on the contrary, what is different between these diseases is the mechanism that causes this disease. That's why we are dividing them based on the causing mechanism. So let's start with the non-inflammatory spontaneous alopecia, which is characterized by the hair cycle arrest. The first mechanism is an abnormality in the hair growth. So it means that the growth of the hair is perturbed, and so we have hair loss, and the hair cycle is interrupted. There is not a new production of the new hair, and we can have two types of mechanism. I will show later. One is the telogenization or the persistent catagenic phase. Here is a schematic draw that is illustrating the different hair cycle stages. So the hair follicle cycle goes through a different phases. So we have in the beginning a growth phase, which is called anagen. Then we have a regression phase, which is the catagen, and a quiescent phase, which is called telogen. And during this telogen phase, the hair follicle is completely at rest, and the club hair is completely formed. Thereafter, there is a new cycle that starts again, and during the next cycle phase, there is the shed of the hair, which is called exogen. There is also a new stage that has been detected, which is after the telogen. There is a moment where the hair follicle doesn't contain the hair anymore, and this is called kinogen. Here in this picture, you can see the hair root of anagen that are smooth, they are pigmented, and when we pluck them out and we look on the microscope, we have the impression that they are like a club, and then they tend to blend a little bit. On the contrary, telogen hair bulbs are generally rough, they are not pigmented, and they are straight, like a spear shaped. The telogenization and atrophy on the follicular root is typical of some hormonal diseases such as the Cushing and the hypothyroidism. We can also see in telogen effluvium and recurrent alopecia. There are, on the contrary, some diseases that present that they have this persistent catagenic phase. Let's start in the beginning with the telogenization. Alopecia is seen in Cushing and hypothyroidism, and this is caused by hormonal imbalance. We have a telogenization of the hair. This is not renew anymore, and so we have alopecia. In a hyperadrenocorticism, alopecia is on the body. Normally we don't have in the head and the limbs. We can also have a post-clipping alopecia, so the owner will tell you, yeah, it was trimmed for an ultrasound, and this was 4 months ago, and the hair doesn't grow back. This can be a clue to help you to arrive to the diagnosis of hyperadrenocorticism. Other lesions are dull and dry coat. We can have skin atrophy and prominent blood vessel. We can have comedones, hyperpigmentation, poor wound healing, secondary infection, and calcinosis cutis. Sometimes they can be really severe, like in this case. Cats can also have more fragile skin, and we can have these cases. Hypothyroidism is another hormonal disease which is associated with the telogenization. We can have alopecia on the trunk. We can have alopecia on the nose. This is pretty typical, and on the tail. Let me show you an example. I saw this dog in consultation, and it was already, you can see that this dog was pretty obese, and it had quite a diffuse symmetrical alopecia, a lot of hypotrichosis on the body. The head was normal, the paws were normal, and if we can see here, we had alopecia on the dorsum of nose, and also the tail was less hairy. This dog had also secondary skin infection, And we perform the blood test, the T4, the TSH, and the T4 was very low and then TSH was high. He had also other problems, hypercholesterolemia, anemia, and we had the diagnosis of hypothyroidism. Hypothyroidism, but we will see in the next presentation, is also associated, like in this dog, to other problems such as sometimes eczema. They can gain weight, lethargy, heat seeking. Another disease is the telogenal fluvium. In the telogenal fluvium, following an event of strong stress such as pregnancy, severe illness, shock, surgery, there is a synchronization of all the follicles. They go in telogen phase. So the hair stops growing to save energy to cope with this illness, and as soon as the illness improves, the hair cycle starts again, and there is a sudden synchronization to anagen, and you see the new hair that allowed the old one falling down. So when the owner see the alopecia, is already late to do the biopsy, because at that moment there is already the new one that is growing, and probably in 2-3 weeks we will have a normal dog. So that's why biopsy are not a lot specific if you wait a lot to take the biopsy. This is an example of our colleague that had telogenal fluvium Charpei 4 weeks postpartum. You can appreciate the extensive alopecia on the face and on the trunk. This is my case. This was a dog that was really severe. He had pancreatitis, and 1 month after he developed this alopecia. In this case, it was not all the trunk, he was on the ventral part and where there are the elbows. And I took a biopsy. This dog absolutely didn't have any systemic signs at the time that I took the biopsy. He had no polyuria, polydipsia. And but anyway, small dog, it was not very young, so I decided anyway to rule out hormonal disease. I did the low dosage of dexamethasone test and also the T4 and TSH, even though it was a very small breed. And then I performed the biopsy, which confirmed that it was effluvium telogen. Recurrent alopecia, it has several names. Actually, we can call seasonal flank alopecia, idiopathic cyclic flank alopecia, cyclic follicular dysplasia, and again recurrent flank alopecia. This is a skin disorder of an unknown pathogenesis. It is thought to be caused by lack of melanin production, which is an hormone which stimulates the production of the hair growth, especially in winter. It's characterized by alopecia that can occur rapidly, and it can normally is bilateral, is mainly in the trunco-lumbar region, and the lesions are not pruritic, non-scarring, but they become quickly hyperpigmented. Sometimes it can be monolateral or more in one side, and honestly, I think this is visually is typical. If you see a particular breed, because it's more represented in a boxer, Airedale, Bulldog, and Border Collie. If you see in this dog, you should think in this. These are very healthy dogs. They do not have other problem. These alopecic areas, they be just 2 centimeters. They come back. They can be big, like in this dog. and normally this is they heal after 3, sometimes even 8 months, but it can take even much longer. In some cases, it can stay also all time. They disappear anymore. They have the tendency year after year to have a progression, and they can arrive to touch each other. So the lesion on the right, they will touch the lesion on the other side, on the dorsum. This is just a aesthetical problem, but if you want, we can anyway try to treat them. We give melatonin, and then we don't know if the hair grow back just because it was at the end of the season, and so it was just a spontaneous regrow. Skin biopsy are important also to help in the diagnosis. Here you can see a boxer, a predisposed breed that had this alopecia on the flank and with the severe hyperpigmentation. And this is a dog that had quite more extensive alopecia. You can see that it starts to be more generalized and the two sides are touching. Here is a hunting dog that also had this problem, and here is a case of a colleague from Belgium which had these rhodesian, which are more, let's say, serpiginous lesions. The same colleague also did her PhD on this topic, and he reported that this is sometime, but I would say rarely. It can also involve other sides, for example, the face, the dorsum of nose, the ears, and also sometimes can present just with different color of the hair. The second pathogenic mechanism is always an abnormality of the hair growth, but is not a telogenization and atrophy of the root, but is a phase which is called a catagenic phase. In this condition, histologically, we can see that there is a lot of tricholemmal keratin, which is we recognize because it's really red, it's really eosinophilic, and we can find this in the follicular lumen. In this classification, we have testicular tumor, alopecia X, pituitary dwarfism, husky follicular dysplasia. Here I put this picture to show why we call flame follicle, because it reminds a bit of the flames. And we can find also in normal dogs, but we find more in this disease. In many of these diseases, the phenotype is similar. They are having hair loss of the primary hair, and they keep the secondary hair. So that's why they have this puppy coat-like appearance. We have this puppy coat mainly in alopecia X and pituitary dwarfism, husky follicular dysplasia, maybe a little bit less in testicular tumor, I found. But let's start with the testicular tumor, Sertoli-Stell tumor. This tumor is more common in those dogs that they retain testicles in the abdomen. So they are predisposed to become tumoral. And if we perform ultrasound, we will see that the tumor that is in the abdomen will have it will be bigger than the atrophic one that stays in the outside, so in the scrotum. They are characterized by truncal chest, and also the hind limbs they can show alopecia. This is a non-inflammatory alopecia. They also have pendulous prepuce and also sometimes also the nipples that are larger, because these are the effect of the hormones that are released by the Sertoli cell tumor. We can have also for the effect of these estrogens, we can have myelosuppression. Interestingly, is this lesion that you can see, you see there is a linear erythema. This is quite typical of this condition. And if you castrate the dogs, this is curative. Pituitary dwarfism. This is a hereditary disease which is associated with proportionate dwarfism. It's an inherited disorder in German Shepherd and Carnelian Bear Dog, where they found it is autosomal recessive. It is characterized by bilateral symmetric alopecia and hyperpigmentation. These dogs, there is no sex predilection. These dogs, they seem normal until the age of 2-3 months, and normal is when they are adopted that they start failing to grow. So we will see that they are more compact, smaller, and with the time they keep this puppy coat because of the secondary hair is the only hair that is still present. They are this soft, woolly, easily epilated hair, and with the time pass, they will have also alopecia. There is also gradual hyperpigmentation, but with the time they really worsen. They start having, they be more inactive. And in the end, they will also have more infection, and they will die when at the age of 3-8 years. Alopecia X is another disease that is characterized by this catagen phase, and is a disease that we can find in plush-coated breeds, such as Pomeranian, Chow, sometimes in poodles. We still don't know the etiology, that's why we call it X, and probably is caused by local hormone problems. It's as I said, it involved the primary hairs in the beginning, but then with the time we involve all hair and we will have alopecia. It's an alopecia that most of the time it spares head and feet, and it involves the tail as well and the body. We will see in the beginning where there is the collar, because the frictions help the hair to fall down, or in the caudal part of the thighs, because when they sit, when they apply, they will weigh on this area, they just remove the hair. It's a diagnosis of exclusion. You have to be sure that there are not other endocrinopathy, and then you can perform the biopsy. However, biopsy is not specific, so the diagnosis is made together with, that is this breed, that are healthy young animal, and then you perform normally they are not pruriginous, and you took the biopsy and you see that they have this special feature that I showed before. This is how it looks, a dog with alopecia X. You can see that there are area of hypotrichosis and alopecia. The skin becomes hyperpigmented. It can be more generalized, like in this dog, and on the tail. And here you can see that it's completely alopecic. It can be less severe like this, but you can see that the quality of the hair is not normal. They are dull. They are, if you touch it, it's not nice to touch these animals. And as I said, it's per the head, always, but not always. For example, this dog, he had alopecia on the head. And I took the biopsy because for me it was absolutely new, and it was alopecia X. The treatment, there are so many treatments, but none are really effective. We can have a new regrowth of the hair with all of these, but most of the time it's just temporary and the hair will fall down again. We can use neutering if they are still intact. We can use the deslorelline acetate implant. Melatonin, we have O-pills or implant. Osaterone is the Ipozan you can give. For example, you give, it's do you have Ipozan? Ipozan is pills that is for hyperplasia of prostate hyperplasia, and it contains just 7 pills. You have to give 1 pill per day for 1 week, and in the next 2-3 months you will have the regrowth. Not all the time. In some dogs, yes. We can use microneedling. I did in some dogs, but when you have this type of patients, the most important thing for the owner is please do not trim the dog. He has already not a very good quality of dog. I don't want that you shave the dog. So for doing this microneedling, you have this tool that you can see here, which has a lot of needles, and then you have to pass very severe in all directions on the skin of the dog to cause inflammation. You have to cause the bleeding of the skin, because we saw that inflammation can help the hair grow back. But if you have a lot of these very woolly hair that are remaining, imagine after the first 10 centimeters that you do, you have all hair inside. So actually, I don't find a lot of owner that allowed me to remove all hair to do this. And also you have to do general anesthesia, because if you want to do very well this, the skin needs to bleed. So yeah, I do, but not always. For sure, I don't use a Trilostan. It's another treatment that should be effective, but there are side effects that I don't want to have. Rarely we have a spontaneous regrow, and as I said, it can regrow after trauma. We can see very well when we do the biopsy and then we put stitches there in that area, probably it will regrow back. And as I said, there are frequent relapses. For example, what I do in let's say, the first approach is to give melatonin. Melatonin is given at 3 milligram kilo morning and evening in the small dog, let's say under 15 kilo. And you give for 3 months. If they have a regrowth of the hair, you can stop even before. And then you stop, and you will use again if the hair will fall again. If they do not respond to this, I will go for or osaterone or deslorelline acetate. However, it's an aesthetical problem. So we have to tell to the owner that the dog is perfectly healthy, and honestly, there is not really need to help to regrow the hair. The only problem is that if you live in a very sunny place, they can get burned. So they need to be protected from the sun, and in winter you should protect from, here no, but in our place, from also the cold temperature. husky follicular dysplasia is reported in husky, and it's most likely identical to alopecia X. So they have primary hair loss, and you can see the quality of the hair is not nice. So let's move to the non-inflammatory spontaneous alopecia, which is characterized by hair structure defects. And in the particular, we will start with the dysplasia that is due to the abnormality in hair pigmentation. So we have color dilution alopecia, black hair dysplasia, and brown Doberman dysplasia. There are several other, but they are so rare, so I just try to give you some information about the most important. So the color dilution alopecia, the color that is interested is the blue color, which is indeed a gray color. We have also in the phone, and there are one or more genetic defects in the melanization. They present aggregates of melanin that they deform the hair shaft and also the root, and so the hair is more fragile and they break in two. It's characterized by progressive changes. So as I said in the beginning, we have hypotrichosis because of the hair fracture, but we can have also complete frank alopecia. They can have scaling, and it seems that they are more predisposed to secondary infection. Here is an example. Of course, when you have this net difference between the hairy and not hairy part, it's maybe easier to find, to understand, or even when you have this generalized alopecia. This is a case that had three colors, one is 4, and this is pretty easy because if you see, the alopecia was only on the gray-blue part, and the red or the white part was completely normal. Here you can see what we saw in the microscopic examination. You can see that the roots, they present a huge amount of melanin, which deform the roots of this hair. This is other cases. They can have generalized, but can be also focal in the beginning at least. This is a Weimaraner. Weimaraner can present a color dilution alopecia. You know that all Weimaraner, they have macroaggregate of melanin if we check in the microscope, but when they have color dilution alopecia, they have much more. They have also another dysplasia, which is called hair follicle dysplasia of Weimaraner, but is pretty rare. And when we took the biopsy, I like to take the region that are middle between hairy and not hairy area, in addition to those in the frank alopecia. We have also the brown Doberman dysplasia. It's similar, it's just changing the color. It's not the gray, but it's the brown hair. Black hair follicle dysplasia. These are dogs that they do not have a diluted coat. This is really black. And they have, differently than the color dilution alopecia that start when they are already quite adult, the black hair follicle dysplasia is in the early age. We start to notice that we have already when they have 4 weeks, the coat changes. So the black hair, they become dull, and then with the time, they have hypotrichosis and alopecia. Like in the case that I show you that had a color dilution alopecia, also for black hair follicle dysplasia, you can have hint when you have dogs that have two color and the loss of the hair is involving just the black area. Also in this dog, two color of hair and only the black was interested. The diagnosis is made on the history, clinical signs. We do the trichoscopy, we also find macromelanosoma and hair shaft defect. We should rule out anyway endocrinopathies, but this is less likely because anyway these are very young dogs. You do the biopsy and you will find the follicle abnormalities. Then we have diseases that are characterized by hair follicle miniaturization. So at least in the beginning, the hair is present. It's just so small that we have the impression that it's missing, but it's present. We have two conditions. We have pattern baldness and alopecia of the pinna and the nose. Pattern baldness is typical of some small breeds such as Dutch Hound, Italian Greyhound, Chihuahua, I would say also Pinscher that I didn't report here. And they have pre and post auricular alopecia, ventral neck, ventral caudal thigh. And we also have in Greyhound, but in Greyhound tend to be more localized to the caudal thigh. Here are some cases that I had, as you can see. This we can really appreciate in this picture. The hair is present, it's just so thin. And I can involve the retro part of ears, the neck, ventrum, and the thigh. And here again to show you how thin is the hair, but is present. In other breed, we can have alopecia of the pinna and the nose. For example, we have in Yorkshire Terrier. It's an alopecia that involves the ears and the nose, and the skin become very, very pigmented. So the hyperpigmentation has also a special name in this breed, is melanoderma, and is associated also with a skin that is very alopecic, smooth. It's sometimes even shiny, and that's why it takes also the name of leather ears, because they have this leathery appearance. And Dutch Hound can also have, but normally it's just on the pinna. The diagnosis is based on the history, symptoms, and the absence of other signs. Is the differential are congenital alopecia, hormonal disease, but if you see the miniaturization of hair, this is very suggestive. You can confirm with biopsy. The therapy is just a benign disease, is also in an area that honestly doesn't bother too much also the more careful owner and that love the herb. So most of the time, even my owner, they do not require any treatment, but you can try with the melatonin if you want. Follicular dysplasia is a familiar disorder. We have in Irish Water Spaniel, Portuguese Water Dog, Curly Coat Retriever, Airedales, but also in other breed. We have spontaneously, sharply demarked hair loss, usually is regional, can progress, but it never becomes generalized. And if we do the trichogram, we will see that there are multiple fractures along the hair shaft, and we can also have multiple hair follicle cast, and so we see that the hair are not normal, and we can have a regrowth of the abnormal hair, but they are never of good quality. Anagen effluvium, we saw before the telogen effluvium. This is much more common. Anagen effluvium is rare, and in special circumstances, above all when we give chemotherapy, for example, antimitotic drugs, or even with severe illness, this can interfere with the anagen phase, and we have abnormality of the hair follicle and the hair shaft. So we will see the hair loss that occur suddenly, and this is within days. The other one was after months. Here is within days after the illness. And with the trichoscopy, we will see that there are irregularities and displacing change of the hair shaft. And we can also have a loss of whiskers. So how can we approach an alopecia? First, we have to understand. First is to ask to the owner if it's spontaneous or self-induced. If it's spontaneous, look at the animal. See if there are inflammatory or non-inflammatory lesions. If it's not inflammatory, you should look for if it's a problem of the hair cycle arrest or if it's structural defect. And this you can help with the history, the physical examination, trichogram, and also in the end skin biopsy. Signalment is very important because if you have a young dog, you should think about congenital alopecia, black hair dysplasia. We saw that they are very young dog, already at 4 weeks of age, and the congenital dwarfism. This happens mainly also in German Shepherd, so if you have this breed, also take in consideration this. Middle age is hypothyroidism. So don't think that the hypothyroidism is associated to old dogs. These are middle-aged dogs. If you have old dogs, and above all if it's a small breed, think about Cushing. Sex, it is important. Male, they can have testicular neoplasia, and female, they can have ovarian cyst. Breed is very important for alopecia. Pomeranian, Chow, Poodle, they have alopecia X. Husky, they can have a follicular dysplasia. Weimaraner, Doberman, they can also have a color dilution. Localization. If it's a flank, recurrent flank alopecia, neck, ventrum, and behind the ears, pattern baldness, the body, but not the legs and the head, alopecia X, Cushing. If it's tail and nasal dorsum, think about hypothyroidism, neck and body testicular tumor. The color of the hair is super important. If it's blue, think about color dilution alopecia, black hair dysplasia. I reported this dog because when I saw it, I thought about, honestly, to hypothyroidism. Look at the nose, look at the alopecia that has on the dorsum of nose. And this dog presents also diffuse alopecia on the body. And this is a magnification of the problem that he had on the nose, the alopecia on the dorsum of the nose. So the diagnosis here is I checked the history, I did the clinical examination, and then I excluded the other cause of non-inflammatory alopecia. It was a dog with a very good health. He didn't have any other signs. He was super active. He didn't gain weight, but with these clinical signs, I anyway took blood and I checked for any abnormality related to hypothyroidism. Then I also did the T4 and TSH. Everything was normal. So in the end, I collected I took a biopsy. And the diagnosis was a recurrent flank alopecia. We saw in the picture that I show you from our colleague Sophie Van den Havel that this disease can also give alopecia on the dorsum of the nose. So this case was just to remember you that you have all the time have in your mind a clear picture of your case, but then be systematic and try to have the best diagnosis. So the treatment in this case, as I said, was not necessary, but the owner was really wanted, so I give melatonin. So thank you. Do you have question for me? Yeah, because I said that we give 3 milligram per dog morning, evening, if the dog is smaller, so let's say less than 15 kilo, but we can give a 6 milligram kilo. For example, this dog that was heavier. Honestly, side effects are not reported a lot. I had a Spitz, a miniature Pomeranian that was so small, it was just a 3 kilo of dog that was very tired. So I switched to only one administration per day, so only 3 milligram per day total. I know that melatonin can interfere also on the quality of the sperm. So if you have a reproductive dog, maybe you would prefer stop the melatonin before reproduction.
It's also indicated in separation anxiety and other conditions.
Oh.
So,
Okay.
did you come across any problem like that?
Not really, no.
Ma'am, what is the treatment protocol for this young black skin alopecia, what you mentioned just now? We also have one small Pomeranian, he's getting baldness and his skin is turning black. So what would be the line of treatment that we can follow for this kind of cases?
For the Pomeranian?
Yes, the mini pom, and they're turning black, the skin is turning black and they're losing hairs from there's only hairs on the head, but all over the body there are no hairs.
So if I understood correctly your question, you are asking which treatment I could use for the hyperpigmented skin?
Yes.
Normally, the hyperpigmented skin is also is caused by this exposure to the sun, because before the skin was protected by the hair, and when the hair is less, so already when it's hypotrichotic, the skin is more let's say exposed, and so it's just pigmented. So ideally, if you don't want the pigmentation, you should protect the skin with an anti-UV body.
What is the management of spontaneous alopecia throughout the years without any skin lesion, without any discolorization? It is a very common practice in our common practicing life that some owner is repeatedly coming, the dog is losing hair without any pruritus, without any skin lesion throughout the year.
I think I didn't understand the question. Okay, if they have a spontaneous hair loss without any clinical signs, as I said, these are aesthetical problems. So you can just monitor and see, so without doing nothing, but it's not what the owner wants. So most of the time, first I give melatonin, and then I can even try osaterone or also the implant of deslorelin. But then I stop, because the other therapy, I think they are too much for a problem that honestly doesn't bother the dog. So even the micro needling, I will have some problem to do it since there is a general anesthesia. The dog needs to be, we have to let bleed the skin. And in theory, you cannot give an anti-inflammatory because is the inflammation that you want. So it's not really gentle. So I will do just if there is a problem for the health of the dog. So for spontaneous alopecia, I try to talk more with the owner and convince them that do not need really a treatment. But melatonin has no side effects, so I give.
Oh, I can give melatonin. Melatonin you are suggesting?
Yes, it's my first choice.
The question is to you. You got the email?
Now, bronze sponsor presentation is going to happen. Mutt Nature is going to.
I'll just make an announcement.
After this, lucky draw. See, after the sponsor presentation, lucky draw will be there. So first sponsor presentation.
Yes, but it doesn't. No present there.
After finishing the.
How do I play this?
Yeah, Dr. Gautam from Mutt Nature will be presenting his.
Okay, guys. So we're just playing a small video. It's hardly a minute. We are announcing the Fasawa Congress in 2023. It's in Mumbai, October 27th to the 29th. And we are having a whole day of dermatology there. And really high-level dermatology. So I'll just play the video, and the link for the registration I will put on the ICVD group. I thank AVD to allow us to play the video. Thank you. Hi everyone, I am Dr. Amni Jairam, board member of FASAWA. We are in the process of organizing the 11th FASAWA Congress. It is the first time this event is going to be held in Mumbai, India, and the venue is the Westin at Powai. We have organized an interesting congress with 6 streams covering a variety of subjects from canine, feline and exotics. World-renowned experts are going to be attending this event. And please take the advantage of learning from their knowledge. We have added an Asian flavor by including leaders from Asia and the Indian subcontinent. The venue is Mumbai, India's financial capital. Please take the opportunity to visit Mumbai. It has a great nightlife and a great tourist spot. Please visit with your families and make this Congress a great success. Thank you.
Good morning, doctors. This is Dr. Gautam, Mutt Nature Private Limited. It's a startup, just 1-year-old company. We have nutraceuticals, cosmetics, pharmaceutical, and vector-specific diagnostic equipment. Nutraceuticals, the silicon J joint supplement, is a synthesis of contratine. Glucosamine, we have the highest, the 5 energy we have. Glucosamine, contratine, and New Green Puzzle. All the 3 counter-protectants derived from marine source. And apart from this, MSM and Boswellia serrata to reduce the inflammation and the pain relief, and vitamin C and hyaluronic acid to reduce the friction, and the curcumin also has been added. So this combination you can't find in this market, and that's why because of this higher strength of glucosamine and this combination, we are suggesting 30 kg body weight, one tablet, twice daily, maintenance once daily is enough. And second one, kidney support. And Astragalus redmonia, these two herbs, the Chinese herbs, known for protecting the nephrons, that we know very well, that we use widely used in our industry. But apart from this, when the kidney issues are there, then the toxins are already there in the system. So how to eliminate the toxins? Through enteric dialysis only we can do that. So FOS, D-mannose and lactobacillus to remove the toxins from the system through enteric dialysis. It's being added. And regeneration, cranberry extract, grape tea extract also has been added. Only thing missing here, the phosphorus binders we don't have, that's also we are planning in the future. Kidmet Plus. And the Kidmet also 30 kg body weight, twice daily, maintenance once daily is enough. And the Yaka Sin, Carica papaya, Carica papaya reverse. Carica papaya, as of now in the market, most of them are using a liquid form. Carica papaya is the better taste one. Mostly the people won't take. So that's why we brought palatable tablets, Carica papaya tablets, not only Carica papaya. So the platelet issues there, the liver enzymes got elevated. So we need to add tinosporan dylarmia to reduce the liver enzymes. And already the pet is anemic, so ferrous has been added. And most of the platelet cases associated with epistaxis, so vitamin K also has been added. So it's a complete package for platelet enhancing and platelet support. Here is also it is 30 kg body weight, twice daily, maintenance once daily. And Hepola liver support, again it is the hepatic Lola has been added. And Sami, many they are having in the market, but Lola, very few they are having that. L-arginine L-aspartate is very much essential to control the ammonia levels in liver. And Silverine is a well-known liver protector. And L-methylfolate, hemopoiesis is required, and again liver issues, vitamin K is required. So Hepola, 20 kg body weight, twice daily, maintenance once daily. All the packs except Silicon J, we have 10s and 30s. Silicon J, 30s and 60s, we have joint support. So EJ 70 for cardiac care, ejection fraction 70 and above, to achieve 70 and above, EJ 70. Again, L-carnitine, L-tarnine, optimum level we have 265 and 250. And coenzyme 10 and magnesium bisglycinate, that is very much essential to maintain BP. And coenzyme 10 we have optimal level 30 mg. In the market only 10 you can find. So optimal level of L-carnitine, coenzyme 10 and magnesium bisglycinate along with fatty acids and antioxidants. This we can use all the senior dogs to protect the cardiac issues and to improve the lifespan. 20 kg body weight, twice daily issues there, otherwise once daily we can do it. So apart from this, we have two specialty shampoos, this apple cider vinegar shampoo and red onion shampoo, first time in India. And apple cider vinegar shampoo, most of the time when the skin infection is there, you are suggesting to add vinegar along with antibacterial shampoo to get better result. So instead of adding normal vinegar, you can use apple cider vinegar shampoo along with antibacterial shampoo to get better result. When the issue is over, you can ask the pet to keep in apple cider vinegar shampoo so we can avoid the further infection. We control the microorganisms. So the shorter breeds, the fungal infections, and it's a very recurrent one. So we can keep the pets with apple cider vinegar shampoo to maintain them. And the red onion shampoo, that is hair fall control. These two first time in India we launched. And apart from this, we have many herbal-based shampoos and perfumes and diagnostic equipments, veterinary specific, because most of the places the human who they are handling, they are dealing with veterinary equipments, and veterinary equipments in many places is not available. So we thought we can fill that gap. Veterinary specific equipment, we can handle the veterinary specific equipments that is reliable, accurate equipments we can bring. So we have chosen the type of instruments. And hematology analyzer, we have the 3-pot and 5-pot hematology analyzer, and economical also. So 60 samples you can do in an hour. So 1 minute, 1 sample, and 1 lakh data you can store, 10.4 inch touch screen, and per test cost also is very much economical. Yeah. And biochemistry, serum biochemistry, fully automated, veterinary specific biochemistry, CMAT is one. And here the advantage is that you can use the whole blood or serum. Whole blood can be used, and within 12 minutes you will get that result. In that rota you need to add that whole blood, and most of the biochemistry instrument will only having electrolyte and coagulation parameters. So CMAT has that electrolyte and coagulation parameters, and very compact one. And veterinary immunofluorescence, veterinary specific immunofluorescence, heel vet here. So in the heel vet, not only these hormones, you can test the cardiac markers and inflammatory markers. As of now, T4, TSH, cortisol, and the progesterone we are having in India. So the requirement comes, we can import many. This is also within 3 minutes you can get the result. Printer is the thermal printer is attached. You can connect with your system also. And ultrasound scan machines, veterinary with software, veterinary software, 5 ultrasound machines are there, U50, U60, U2, and Atlantic LX2. OT lights, OT tables, and the flat panel detectors, because now they are all moving to digital X-ray. This is the ultimate one, the recent one from Korea. 3 kg weight only is very easy to carry. Up to 300 kg weight, we can use this flat panel detector, and it's a Wi-Fi connected. So within 2 seconds, your preview will be in the system, and up to 1,600 images you can store, and scratch-free, water-resistant. This is the ultimate one. And anesthetic, anesthesia workstation, and trolley type. 4 and Indian assembled model also we are dealing with. And underwater treatment for hydrotherapy. So, and some more dermatologist specific instruments we are working on. Narayan has suggested. Before that Mumbai conference, I think we will be having that one. Thank you. I want to thank Narayan sir for giving this opportunity, and all IAVD team. Thank you all.
thank you for your cooperation and thank you for this opportunity to provide AVD team.
Guys, the sponsors are very, very important. All the guys who supported us, we want them to support us next year also. So please do support all the companies. I invite Dr. Pandit from Fridun. Fridun has no presence in Kerala, but Fridun just came because Nagarajan sir said, please come. So Dr. Pandit, please.
Good afternoon, everybody. I will correct Dr. Jairam. I am from Fredun. Fredun is the mother company, and our division is Freossi. Freossi. That I is a bone, so a lot of people call it Freos. I'll not take much time. So let me tell you about Fredun Pharmaceutical. The presentation is still to be loaded. Fredun Pharmaceutical Limited is a listed company, and it engages into human pharma. So we basically are a human pharma company which operates into 47 plus countries. We are exporting. We are B2B, we are not B2C, which means we are not business to customer, we are business to business. So whatever we make, we export. Whatever we make in India is also made for some companies. For example, USV, all the diabetic range is made by us. Many of the HIV products which are made under license are made by us, marketed by somebody else. So we have around more than 500 APIs, more than 5,000 formulations. We recently started generic where we are doing human generic formulations, which is again marketed by somebody. So to come to the human space, from the human space to the pet space, and be present all over India, we have taken some time. We are only 1.5 years young, and we started with 5 products, and today we have 30. In the next coming years, we will be 100 plus products. We are not only into MCSC based. MCSC is our base molecule. The story goes, microcrystalline hydroxyapatite complex is a molecule of not Indian origin. It is a molecule of a Swiss origin, and this MCSC was actually was distributed and sold worldwide by Sanofi. So TTK wanted this molecule into India, and the story goes that So story goes that because it was very expensive, they were looking for somebody to synthesize it. Now MCSC, microcrystalline hydroxyapatite complex, can be synthesized only from the long bones from the bovines, not from the short bones, not from the flat bones, not from the irregular bones. So this requires a proprietary, and that required a specialty. So they identified a Parsi lady. Her name was Dr. Daulat Medora. And she started her work along with her team on a synthesis of MCSC from the long bones. And she was successful, and she was given the rights. And then she started to make it in India. So this was a Make in India product 40 years back. And then they built a factory in Palghar, 100 kilometers away from Mumbai. And MCSC MCSC was then given to TTK. So TTK has a very famous product in bovines. It has MCSC. We are the suppliers of MCSC. Today we are the largest producers of MCSC in Asia. MCSC based product used to be 1% of our turnover. Now, was 90% of our turnover. Today the same product is only 1% of turnover, and we have 18 divisions now. So we started with the MCSC. We are 18 divisions. We are very diversified. We are into multiple things. Like textiles, we are into dental, we are into Nutra, we are into a lot of things. We are into packaging. So we diversified. So let me start the presentation. So this is Freossi. So thank you, Dr. Nagarajan. Thank you, ICVD, for giving me this opportunity for presenting my company. It's very difficult to present a company with such a lineage and such a long divisions, but then I will make it in 3 minutes. So this is Predun Pharmaceutical Limited. Actually, this is our stall. This is our first sponsored stall in PPM. You can see what we did in PPM. The first time we sponsored it, we put a massage chair there. And all the veterinarians, because we feel in such kind of events, where it's a meet the industry event, such kind of events, veterinarians want to lower down their guard, enjoy their life, and then they come to us and we talk about products. Not done. Am I right? Such kind of programs not done. In a program like this, we want to present our products. So we wanted doctors to chill. So we did proper scientific feet massage. So this is the first sponsorship of ours. The second sponsorship we did a carnival where people came and played games. But we never showcased our products. So this is what we did, and we will continue to do this. So I already told you about Predun Pharmaceuticals, I already told you about the lineage, I already told you about Dr. Daulat Medora, and the way she was like instrumental in bringing MCSC in India. So we have a plant where we can produce 3.5 crores of tablets every day, 2.5 crores of capsules every day. We can make pellets, we can make capsules, we can make granules, we can make cosmeceuticals, we can make pellets, we can make dry powders, oral suspensions, and topical gel, ointment, and cream. So we can do all this in our plant. So Predun Group is dedicated to improving the lives of people since their inception in 1987. I will skip this. This is about Dr. D.A. Medora, who obtained her PhD in chemistry from UDCT. So she is a scientist. The first generation of this company is a scientist with a PhD, and it's not something like a lot of money was there and you start a company. We have made the money through products we have invented. So he is the current managing director of the company. He is 36 years old. His name is Predun N. Medora. And he is highly educated. He is educated in USA and UK. So these are our divisions, some of the divisions which I want to showcase to you. These are the countries where we are present, and there are many more. So this is the range which we have right now in PET. So we are into mobility and lactation supplements. The MCSC or the microcrystalline hydroxy apatite complex range is made from proprietary research of the founder of the Predun Group, Dr. Mrs. Daulat Medora. This is the flagship product of the range of Reosi. Those who have tried these products, they know the beauty of these products. We also introduced a product known as Daily Power, which comes in a sachet. So this is what I have understood through my experience for last 24 years into the pet food segment. 80% or maybe more of the dogs are on homemade diet. And they are not on a complete balanced dog food. And even if they are giving complete balanced dog food, they are giving it as a breakfast or maybe 5 kibbles or maybe half the meal. Rest of the meal is homemade. And with the Indian thought, it is very difficult to change it. Though it is not completely balanced, they want to give a homemade diet. So how to make it balanced? So we introduced this Daily Power, which is a supplement which can use daily into the food of the dog. Then we have therapeutic range. The therapeutic range is designed to holistically support the entire pet's anatomy during illness and wellness. Then we have a pet grooming range. India's first personalized pet grooming range is here. All our products are safe, effective, and natural. Pet grooming range is made up of 3 subcategories: personal care, fragrance care, wellness care, and destroyer range. Then functional dog treats. This I started doing it when I joined this company on 1st of December. So today we have 3 flavors. It's a flavored, milk flavor, mutton flavor, chicken flavor, but it has Brahmi and MCSC, so it is slightly functional. But our next range which is coming, which will be completely functional. It will be for gut, for joints, and for the skin. And many more to come. I will not declare right now, but would say expect the unexpected. So this is the range which we have. India's first gel-based solution for gingivitis, stomatitis, mouth ulcers in pets. So it has chlorhexidine gluconate, it has metronidazole and lidocaine. So this is methyl glow. Then we have luricanazole. This is more apt to the conference I am attending. So luricanazole is indicated for treatment of interdigital tinea pedis, tinea cruris, or tinea corporis infection caused by Trichophidon rubrum and epidermorphidon paroxysm. So this is the composition. So we have a platelet booster here to boost the platelet count in anemia, thrombocytopenia, tick fever, to support during chemotherapy, to regulate the functioning of liver and immunomodulation, to support during the treatment of flu and viral infections. So this is play up. Then we have ICVD2, nutritional deficiency anemia, parasitic anemia, hemolytic anemia, hemorrhagic anemia, and debility and convalescence. This is ICVD2. This is blood tray. Blood tray you can use as a supplement to keep bladder and urinary tract healthy. I do a clinical nutrition practice, and I have started to use some herbal supplements during making of a product. Like for example, in a kidney diet, I have started using chlorophyll. We are looking at the result, how it is performing, and then this is immunofray. This is for immunity. This is gut bread, prebiotic, probiotic supplement. Then this is caprofen, again a painkiller. Then we have this unique product known as pimobendan, for the heart, pimobendan plus CoQ10 plus vitamin E. So we also have prednosil for the liver. This is the personalized grooming range. I will not get into details of that. We have functional treats. This is milk, chicken, and mutton flavor. These are the next coming as Snacky Plus. We are also into diagnostics where we do 3D printing. We do 3D printing. I would like to show you a skull. It's over. My presentation is over.
Next, Himalaya team, please come over.
Good afternoon to all. My name is Madhivan, General Manager of Tamil Nadu. I am coming from Himalaya Wellness Company. Thanks to giving this opportunity for Dr. Nagaraj sir and IAVD team. Firstly, we given only 4 products only. Don't worry, 3 minutes I finish it. First, we introduced Himalaya Healthy Food. Past 3 years before we launched Himalaya Healthy Food Puppy. Himalaya Healthy Food for Puppy, complete and balanced nutrition for dog. Himalaya Healthy Food added black pepper. Black pepper is an immunity modulator and support immunity. And Himalaya Pet Food, we added oats. Oats helps in maintaining healthy skin and shiny coat. And added papaya also. Papaya is a digestive stimulant and support for digestion. And Himalaya Healthy Food adult. In adult added propola. Propola is an probiotic that supports kidney functions. And TFN, TFN is a metabolic stimulant that promotes metabolism. And guduchi. Guduchi is an immunity modulator and antidiabetic which supports immunity and promotes glucose metabolism. And Mobility Plus, joint and hip supplement. In Mobility Plus, we added glucose. Glucose is an anti-inflammatory. Glucose helps reduce pain and inflammation of joint and hip. And Mobility Plus, we added ginger. Ginger is anti-apathetic and analgesic. Ginger helps reduce pain and inflammation. And fourth product, Ruminfla. Ruminfla is a dual action spray. This is first in industry. In Ruminfla, we added Devaduru, anti-inflammatory and antimicrobial, and we added Arida, antiseptic. It prevents release of inflammatory mediators on which smooth wound related edges. It is also an antiseptic that helps wound quickly. Thank you. This is a new 4 new products. Thank you to all. Thank you.
Ball metabolism, decrease hydrolytic size, and reduce.
Good afternoon, everyone. I am Sriram of JK Pet Products INC. This company is 23 years old company started by pet parents and pet lover. We have been pet food distributors, pet pharmaceutical distributors, importers and retailer. It is important to note that veterinarians have been a major contributor to the growth within. It is important to note that veterinarians have been a major contributor to our growth with their knowledge and dedication. I will mention two people in this short time. Late Dr. Junius Daniel, a veterinarian PhD, and late Dr. Haider Ali, a traditional Siddha practitioner. The knowledge and experiences we have gained during these years in contact with veterinarians, breeders and pet owners have helped us to understand their needs, like incurable diseases that they face. Having successfully treated humans with natural remedies, we created this brand Healthy Pass after 15 years of research and development. Our mission at Healthy Pass is to discover and research natural and innovative treatments and cures for diseases that are incurable in the present day for animals. We are introducing our two product lines, Derma Care and Renal Support. This is Derma Care. It's a natural treatment for skin and coat problems such as atopic dermatitis, sarcoptic mange, canine demodicosis, fungal and antibacterial infections, and other skin problems. We all are gathered here for dermatology. These products cure all these skin infections. Okay. The next product is Renal Support. Renal Support is a dietary supplement in the form of liquid which enhances renal function, increases hemoglobin level, improves breathing, improves blood circulation in dogs and cats, rejuvenates kidneys and other organs. It is recommended that this product should be used in conjunction with allopathy. So keep supporting us, which motivates us to bring new and innovative products. Thank you, Association of Dermatology, for giving this opportunity.
Good afternoon, doctors. I am Kishore from Tamil Nadu. I am behalf of Vetina Healthcare LLP. We are having such unique products. I would like to share one of our unique products. Just a 3 minutes video, sir. Please bear with me. Thank you.
Osteoarthritis is a leading joint degenerative disorder seen in dogs, which show unexplained pains in their limbs and swelling of joints. You may often find them whimpering in pain every time they try to jump, run or walk. Why does this happen? This condition causes long-term degeneration of joints, including many tissues like cartilage, bones of the joint capsule and synovial fluid. This results in stiffness, lameness and pain. Pentos is being introduced as an easy solution and treatment to osteoarthritis for your dogs by Vetina. This module is classified under TMOAD, disease modifying osteoarthritis drug. It constitutes of an active ingredient called pentosan polysulfate sodium that is derived from a plant source called beechwood, most commonly used as an injectable drug to treat osteoarthritis in animals. The pentos works by acting at multiple junctions in the interconnected pathway of pathological changes occurring in the articular cartilage, subchondral bone, joint synovial lining, and the synovial fluid in an osteoarthritic joint. Degeneration takes place when mechanical factors act on healthy cartilage and subchondral bone, causing the release of proteolytic enzymes that break down the healthy tissues, as well as cause the synovium to get inflamed, which leads to an abnormal synoviocyte metabolism, decreased hydrolytic size, and reduced viscosity and lubrication of the joint, finally leading to the breakdown of the cartilage and damaging of the bone. The damaged bone further causes synovitis, thus repeating the same process again and again until the complete loss of bone or joint function. What pentos does is that it acts at a number of points simultaneously, breaking the chain and creating favorable conditions for bone regeneration activities. It inhibits the proteolytic enzymes and decreases the loss of proteoglycans, as well as inhibits destructive enzymes like interleukin-1, interleukin-6 and TNF-alpha. Due to exhibiting partial heparin-like qualities, it also breaks down blood clots to increase blood flow to the joint. which cures bone necrosis and sclerosis and also reduces inflammation and pain, and finally increases the hyaluronic acid concentration in synovial fluid, leading to increased viscosity and lubrication in the joints, thus initiating corticoid regeneration of the damaged cartilage and bone. This Pentors works on many types of conditions, including osteoarthritis and traumatic joint diseases, osteochondrosis discans, degenerative cartilaginous joint diseases, musculoskeletal disorders, and periarticular inflammation. Plus, it has been proven to have zero side effects due to its origin being plant-based, thus being a completely safe drug for the dog. Choose Pentors. Relieve pain, restore function, renew hope. For inquiry, call or write to us on 912067 445858, 91750 Email ID customerservice@vedina.com. Visit us at www.vedina.com.
Thank you, sir. Thank you for the opportunity. Thank you. Good afternoon, everyone. Welcome, delegates. And before starting my presentation, I would like to extend my special thanks to IAVD team for giving this opportunity and organizing this event. I'm Dr. Vipul with PMT team of INTAS, specifically with Companion Animal Division. You all are aware about our products, which wide range of therapeutics and nutraceuticals we are having. Today I'll be covering up a very special brand, biologicals, which is very crucial in preventive medicine. Slightest of temperature deviation could compromise on the promise which is there, and same holds for is true for the active immunization as well. There are crucially rather there are three important aspects which are involved in this. One is the phylogenetic similarities and the titer value of the vaccine, the cold chain management system, and after that another crucial point is the post-vaccination do's and don'ts, which you all inform to the pet parents after the vaccination. Before moving on to these 3 points, we are the have a technical collaborator with CAVAC, which is one of the leaders in vaccine manufacturing. This is the #1 animal manufacturer in Korea, and they have vast experience of 55 years in this vaccine manufacturing. They have expertise in vaccines and diagnostics, and they have more than 80 products globally in this both vaccines and diagnostic range, and they are present in more than 20 countries right now, and they have the global level facilities available for this vaccine manufacturing. Coming to the phylogenetic similarities, they are very important as the strains which are causing in a particular geographical area will give more immunogenic response if they are of the same origin. So Indian field strains were isolated, and they were found to be phylogenetic similar up to 99.9% with the strains which are used in Canishot DHPPL. Whereas in the clinical efficacy of the Canishot DHPPL, every titer value were as per the Wasava guidelines and way above those titer values. So the efficacy and the potency of the vaccine is that what is because of the phylogenetical similarities which are there in Canishot DHPPL. These are the strains which are being used in our vaccines, different vaccines. The cornerstone which gives highly immunogenic response and gives protection against all type of CPV viruses, whether it is 2A, 2B and 2C. And in December we have the Rockpond strain. For hepatitis we have used the Manhattan strain, which gives the high immunogenic response even in the presence of MABs, maternal antibodies.
Also for parainfluenza, the corneal strain is used, which is the initial, and for the rabies, pasture strain, the original pasture strain has been used, and which gives a very good BEI. And it has the unique tissue culture, and that is why this is in the lyophilized form, Canishot RVF, which is more thermostable. Even if it is kept out for a longer duration of time without the cold chain maintenance, it will give the same results. And the advantage is with this Canishot RVF is that only one dose is required. No boosters are required. Only annual boosters are to be continued. One dose is sufficient to give the immunity which is required to protect from rabies. And simultaneously, it can also be used as a post-bite vaccine in rabies cases, because it is having more than 2.5 IUs of titer. As recommended by Wasawa, it should be minimum 1 IU. So you can also use this Canishot RVF in a post-bite vaccination cases as well. Moving on to the cold chain management system with the state-of-the-art cold chain management assurance. We ensure your promise are met every time with the world-class logistic. We are using this cold chain management system which are meant for the humans, and we are adopted it in the animal health. So this assures the 100% temperature and quality assurance we are giving this. Although this vaccine comes from 10,000 kilometers away, but each and every step, this temperature is maintained at every second. So that the compromise is not there on the temperature as well as quality of the Canishot brand. For this, we have data loggers placed at every second, and we have equilibrium system with every second which checks, and if any data variation is there, mail and SMS is sent to the concern immediately, and immediately corrective actions are taken. And you all know the post-bite vaccination is just not sufficient. After the vaccination, at least 15 days it should be given to the pet, and advised to the pet parents that it should not be in contact with the other dogs, because immunity takes some time to develop. Right, and the nutrition is very much important, and the follow-up and the complete vaccination protocol is very much important. Thank you everyone for your time.
Good afternoon, doctors. I am Swaminathan from LabX, and we are doing the complete diagnostic solutions. And I want to thank AVD for giving us the opportunity for participating in this program. And what is the unique is we are providing the complete solution only for diagnostics, and most of our testing parameters can be done by point of care, which is very much important for your identification of the disease conditions. I will just play a video about our instrument Exigo.
With its innovative technology and outstanding performance, accuracy, and quality, Exigo H400 is a leading veterinary hematology analyzer. It provides a complete blood count, including a 4-part differential. The analyzer also has a built-in mixer system, allowing efficient sample mixing while saving bench space. It is also a true 4-part system, meaning it has a reagent-based eosinophil method for its 4-part differential, a quality method for one of the more difficult parameters you need to measure. Eosinophil count is a great help for veterinarians to screen for parasites, allergies, and other diagnoses. Whatever the sampling method, you'll see the results on a full-color touchscreen. Exigo H400 lets you decide how you view results. Choose between histogram or reference scale views. The units, parameters, scales, histograms, and orders they are presented in are all settable. Exigo H400 also helps the veterinarian through pathological information flagging. Printouts are fully customizable as well and cover any or all of the parameters, flags, and notes you choose to display. Better connectivity and improved communication protocols are also key features of Exigo H400. It can easily be connected to a PC or USB or LIS system via, for example, the HL7 protocol. It is also possible to export CSV files or customizable PDF files. Operating Exigo H400 veterinary hematology analyzers couldn't be easier. The intuitive touchscreen quickly guides you through the menu options at your disposal. Loading patient ID information or operator ID is just as simple. Use the touchscreen or integrated barcode scanner for fast and secure data transfer. Exigo has an advanced software and comes with 12 pre-installed species profiles. Every profile uses a dynamic approach in analyzing the sample for the most accurate result for that specific species. In addition, Exigo gives you the flexibility to develop your own profiles. Exigo users globally have added more than 50 different animal profiles to the analyzer. These have been added through following our internal procedures with settable software adjustments.
Thank you everyone for your time. Thank you.
Very good afternoon to all honorable veterinarians. Myself, Divek, I'm handling business of South India from Perfect Companion India. So all of you know our familiar brands Mio cat food and Smart dog food. So recently we have added one more super premium product in a dog food category. Just I would like to play the video. Please give your time, please.
Because dogs are special members of your family, you must be committed to providing them with the best care. We all want the best for our loving companions. Smart Heart Gold is the super premium quality dog food for your dog's overall health. We give your dog the special care it needs by selecting the highest quality ingredients. Our super premium quality and well-balanced diet is formulated with single animal protein source as the #1 ingredient. This limited protein source formula helps minimize food sensitivities with no proteins from chicken products. Additionally, there is no corn, wheat, no artificial colorings, flavorings, or preservatives. The main carbohydrate source from rice is easy to digest and absorb. Essential omega-3 and 6 fatty acids from sunflower oil and flaxseed help for a lustrous coat. Fiber from beef pulp helps improve the digestive system. Yokashita hair extract helps control stool odor. Natural antioxidants from rosemary extract and vitamin E help slow body degeneration. Smart Heart Gold with 2 special formulas, salmon meal and rice. Salmon is the #1 ingredient and the main protein source and help build strength. Being rich in EPA and DHA omega-3 fatty acids helps promote proper brain function. Omega-6 fatty acids help with skin nourishment and a lustrous and fluffy coat. Additional natural antioxidants help promote your dog's overall good health. Lamb and rice. Lamb is the #1 ingredient and the main protein source, containing natural glucosamine and chondroitin, which helps strengthen joint function. Additional prebiotics help enhance the digestive system and promote a healthy immune system. For puppies who are special members of your family, Smart Heart Gold doubles the amount of EPA and DHA to promote functional development of the brain and visual function. Additional GOS prebiotic, naturally found in mother's milk, helps build the immune system for your puppies to grow strong and healthy. Over and above being special, we want to ensure that we provide the best care and the best health to the dog we love. Smart Heart Gold, beyond goodness.
Thank you so much for the entire IAVD team for this great opportunity. Thank you.
Okay. So, the skin has many structures, right? We have the epidermis, we have the dermis, we have the hair, we have the adnexa, the sebaceous glands, we have pigmentation in the skin. So any of these structures can have a genetic defect, of course, right? So I have made a selection of the genetic defects that are more frequently observed in cats. All these diseases are quite rare. So just sit down, relax, like in a travel. When you go on a plane, they say sit down, relax, enjoy the travel, because this is going to be sort of a show of what can be seen, but this is not really very common. So we start with diseases of the epidermis. And the most important disease is epidermolysis bullosa. What happens here is that the molecules of the basal membrane are defective. Now we have talked before about the diseases where these molecules of the basal membrane were attacked by the immune system, right? It is the same problem, but they are defective without the attack of the immune system. This is a genetic problem. So what happens is that the epidermis will detach from the underlying dermis because this attachment of the basal membrane, the hemidesmosomes, they don't work well. That's a genetic defect. So we have two types of epidermolysis bullosa. They actually look identical because what we see is the sloughing of the epidermis, the dysepithelialization. So we have erosions, ulcerations, and sloughing. So I'm going to show you, these are the molecules here. We have seen them before, and these are the lesions that we see. You see erosions on the ears, on the lips, and histologically, this is the epidermis, this is the basal membrane, this is the underlying dermis. The basal membrane is not working well to attach the epidermis to the dermis. And so what we see is the detachment of the epidermis from the underlying dermis. And so if the epidermis is missing, you have this erosion. And the same is here, you have some vesicles underneath. And that is epidermolysis bullosa dystrophica. What is the difference between these two diseases? The name and also the molecule that is defective. But the result is exactly the same. We have a detachment of the epidermis from the underlying dermis. And these are the very few cases that have been described. You see that there is no epidermis on the foot pads. The mucosa is missing on the mouth and on the feet. These, of course, are diseases that we see in young cats. And the lesions, they develop mostly on areas of friction where there is some mechanical trauma and the epidermis will fall out. So we see that usually on the feet where they walk and in the mouth, because eating causes a mechanical trauma between the food and the mucosa, and there is where we see the lesions. Okay, now let us see diseases of pigmentation. You have seen vitiligo before. Vitiligo is an immune-mediated attack to the melanocytes. But sometimes these melanocytes may be defective. Well, we have different types of defects of melaninization, of depigmentation, and I'm going to cite just two. One is albinism. So the melanocytes are in the skin, but they don't work well. An enzyme is missing, and this is tyrosinase, and this enzyme is very important for the production of melanin. It converts tyrosine to melanin. If this enzyme is missing, we cannot produce any color. And these are nice cats with a white coat and with blue eyes. Now you know that of rabbits, for example. The white rabbits, they have blue eyes. Or they have even red eyes because they lack completely the pigment. Another one is the Waardenburg-Klein syndrome. And that is different because in this case, the melanocytes don't reach the skin. They are lacking. The melanocytes are formed in the neural crest, and then they migrate to the whole body. And the animals that have white feet, it is because the melanocyte didn't make it to the tip of the feet, they only stopped at one level. The same for horses, for example, for collies. Now, when they don't migrate at all, you don't have any melanocyte in the skin. The problem is that you don't have them also in other areas where they would be very important. For example, did you know that we have melanocytes in our hearing organ? So if they don't reach the hearing organ, these animals will also be deaf. And so these cats or dogs with a white coat, many times they are deaf. In this case, it is not albinism, it is Waardenburg-Klein syndrome. And you should not breed with these animals, of course. Vitiligo, it is an inflammatory disease, but I mention this here because it has an extremely important breed predisposition for the Siamese cat. So it is like there is some genetic problem there that cats develop vitiligo. Okay. And then we have hyperpigmentation. I'm sure that you know in the red cats, this is also congenital, these black spots. I mentioned these, this is lentigo. It is absolutely a physiological problem. But I had many owners come to me for a consultation because they were afraid that their cat had developed melanoma, malignant melanoma. So you should expect that some owners come to you and you should tell, no worry, this is just freckles. You say freckles here? It's just lentigo. I don't think that Indians have a lot of freckles, right? No, it's usually the Irish people, right? Yes, okay. So this is just lentigo, not a problem. Okay, so these were the main diseases of the epidermis. Let us look at genetic diseases of the dermis. Now, what do we have in the dermis? We have collagen fibers, we have elastic fibers. And collagen and elastic fibers are there to offer resistance to friction, to traction. But if these fibers are missing, you will not have this resistance to friction and to traction. So look at here. Now you can lift skin folds that are very, very big. There's no resistance to traction. You can really make big skin folds because of the lack of this congenital defect. This is called cutaneous asthenia. In humans, Ehlers-Danlos syndrome. There are many different types of Ehlers-Danlos syndrome depending on the genetic defect or dermatosparaxis. Not only it does not offer resistance to traction, but also it will open up if you tear it. So look at this. These are kittens that when you do this with the skin will actually tear because there is no resistance to mechanical trauma. Now this is compatible with life, but these cats should be indoor only. They should make a very quiet life. They should not scratch themselves, so they should always have the nails cut or maybe even the nail caps on their nails, because if they have pruritus and if they scratch, they will cause these diseases. Now we have seen similar images before when I was talking about skin fragility syndrome in animals that were taking too much corticosteroids. Now it is very similar. However, these are kittens and did not take any corticosteroids. So this is a genetic defect. If you see it in adult cats that are old, have Cushing's, have diabetes, were treated with a lot of corticosteroids, then we know it is not the spontaneous hereditary form, but it is the adult onset form. How do we say that this skin fold that we lift is exaggerated, is pathologic, and thus my cat has this disease? Now, there is this nice formula. So you take the vertical height of the skin fold times 100 divided by the body length from the neck to the attachment of the tail. If this is more than 19, then you have this disease. I think it is nice and interesting to do this. In dogs it is 14. So it seems that cats stretch their skin much more. This is one case I had. You see, you can stretch the skin very much. This cat also had a big lesion here. And look at the pose. these are not normal pose. He has like some laxity, so the whole collagen, also of the tendons of the joint, is defective. He's not walking in the right way. Okay. What happens with these cats? Now, you see, these are the collagen fibers, and they are all detached one from the other. They are not in an orderly. This is what should be normal. You see, they are all hexagonal in packages, and here the collagen fibers, they are all messed around. So this is quite obvious that it is a defect of the collagen fibers. Okay, another strange thing that I have seen in I had a bottle of water, right? Can I have a bottle of water? Thank you. That I have seen is lymphedema. This is also a defect, thank you very much, is also a defect of, a genetic defect of the lymphatic vessels. So look at here. This is the epidermis, this is the dermis, and these big holes here are the lymphatic vessels that are dilated. So it can be a problem of the vessels, it can be a problem of the drainage, for example. The net result is that we have a lot of lymphatic stasis in the tissue. And look, the face of this cat, it looks like an extraterritorial. There's not very much that you can do with these cases because this is a congenital problem and they will have this swelling for the rest of their life. Lymphedema. Okay. Now let us see the diseases of the hair. Now in cats there is a lot that has been studied, described, developed, done with genetics of the hair. And we know, for example, that some genes determine the coat type. For example, we have a gene, keratin 71, that determines the hairlessness in the Sphinx cat and determines the curly coat in the Devon Rex. In fact, Sphinx and Devon Rex, they are related. There is another gene, LPAR6, that determines the curly coat in the Cornish Rex and in the German Rex. So the curly of the Cornish and German is different than the curly of the Devon Rex. It gets more and more complicated. And then there is a gene called FGF5 that determines the long hair in many breeds. So we have many types of cats with different gene types, and this is determined, of course, genetically. Now, we have two breeds, the Sphinx and the Devon Rex, you see here, and both this phenotype depend on the same gene. But they are very different because the Sphinx is completely naked while the Devon Rex has some hair. So why is this? Because this keratin 71 gene has two different types of defects. In one type, it is so pronounced, it is called an HR allele that has a complete loss of function. So the hair cannot grow at all, or they grow so badly that you cannot see them. And this is what happens in the Sphinx. In the Devon Rex, the gene has a defect that is not so bad. It may allow the growth of some hair. So it is a partial loss of function. So that we have some hair. It is not a normal hair, it is very short, it is curly, but at least we have some hair there. Now, in Sphinx cats, what happens? Because these cats are completely naked. Well, there has been an article that has analyzed what is the problem with the Sphinx cat. And they are not naked in the fact that the hair is not there. The hair is there. The hair density is normal, but the hairs are so dysplastic that they cannot grow very much, so that we don't see them. A little bit like bald people You don't have many bald people in India. Well, some yes. Okay. We have much more. So you still have all your hair on your head, but they are so small that we don't see them. This reassures you? Okay. Yes, but all the energy is going in the brain, you know. He's very lucky. So the same happens in the Sphinx cat. This is a normal cat, and you see the hairs are there, they are long. This is the Sphinx. You see that the hairs are still there, but they are so small that we don't see them. And this is a diameter of a normal hair. This is a diameter of a Sphinx hair. It is very small. It is dystrophic. It is melasic. We don't see it. Now, you may say, but these are normal cats. This is a breed. This is not a genetic defect. In fact, Sphinx, Devon Rex, they were all created from genetic defects. So one day, in one cat, there was a genetic defect that was born, and it was bald, and they have taken that cat and have said, hey, that is nice. There may be people who want to have bald cats. Let us use this defective bald cat for breeding, and they have created Sphinx. They have created the Devon Rex. So there are still naked cats of any breed that are born, because that is a defect that can affect any breed. Then if you take those animals to create a new breed, that's another thing. So here you see that congenital alopecia can occur once in a while, and these are some cases that were given to me by some Italian colleagues. They had some cases of cats that were born completely bald, you see. These are, I think this is the normal one, and that is the bald brother. Now there is one breed especially that has a congenital hypotrichosis, and that is the Burman cat. But we have to be very careful, because this is a disease that can be fatal in this breed. Because it is a deletion of a gene that is very important, because it is expressed in the thymus. And so if you have a defect in that gene, you have an important immunologic defect. And so these cats, they die of respiratory infection, of respiratory signs. So this is a big problem in the Burmese breed, thymic aplasia, spleen lymphocytic depletion. These cats don't survive very long. So what else can happen with the hair as abnormalities? So we can have many congenital abnormalities in humans. You see there are all the different types of defects that you see in humans. In fact, in cats, we know these Trichorexis nodosa, and the other one, I cannot read it. Hair casts. So this is one case that has been published of Trichorexis nodosa in a cat. And you see on a regular interval, there are defects in the hair shaft. These defects are like an onion, and here, of course, the hair breaks more easily. And this is why the cat looks hypotrichosis. That's another case of another colleague that has given me these photos. Then we have another disease called pili torti. The hair is flat, is not round as a diameter, is flattened, and is coiled. So you can see it is like a spiral. It is coiled on like a spiral. This is what has been published by Silvia Colombo. This is another publication. And this is the publication by Silvia Colombo, where you have this cat that has hypotrichosis, has spiral hair, and has spiral roots. You see, these are the roots. They're like a corkscrew. You were also in this publication. Okay, sorry. Sylvia and Elisa. Because Elisa has been resident of Sylvia and myself. And so I remember that Sylvia gave me this hair. Did not remember that Elisa was there too. Okay. Now these were the abnormalities of the hair. Let us see the abnormalities of the sebaceous glands. And this is sebaceous gland dysplasia. This is seen in kittens. They have hypotrichosis. They have scaling, crusting, a little bit like a sebaceous adenitis. There is no lubrication in the skin. And when you do a skin biopsy, you will see that the glands are really dystrophic and atrophic. And the lesions appear in kittens when they are young. Okay, so that was more or less an overview of genetic diseases, but I would like to show you a little bit of the few breed-related diseases that we have in cats. In dogs, we have a high amount of breed-related diseases. In cats, we don't have many. So the Persian cat, of course, you know it has a predisposition for dermatophytosis, and this is a dermatophytic mycetoma, so they also can have a deep infection in the skin. Yesterday we saw that they can have apocrine cystadenomatosis. We saw it in the ear lecture. And this is not only in the ears, you can see it around the eyes, on the face. This is next to the vulva. And these are blue cysts. They are full of sweat. We have talked also about the dirty face disease, typical of the Persian cat. There's nothing that you can do but to clean this face. There is one disease of the Bengal cat. Do you have Bengal cat? I mean, it should be an Indian. Bengal is here, right? We have the Bengal tiger with Sandokan. You don't know what Sandokan is, but... okay, the Bengal cat, it has a nasal hyperkeratosis, which has been described only in the Bengal cat. And then we have diseases of naked cats. Now, why should one person buy something like that and have it at home? I think it's horrible. It's scary. Looks at you like Gollum. Did you see Lord of the Rings? Gollum? It's the same. Okay. So, they are full of malassezia. So, on top of this, they are ugly and full of malassezia. In the ears, in the nail beds, between the toes, this is absolutely normal. Don't do anything. If they don't scratch, don't have pruritus, this is just the normal flora of the naked cats. They can have urticaria pigmentosa. This is a line or dotted papules that are full with eosinophils and mast cells. They may be pruritic. You can use cyclosporin. What we use is cyclosporin. You make a biopsy, you see lots of mast cells. Here you see them. These are the violet things are the mast cells. Here there are lots of eosinophils. And remember that you can also have dermatophytosis in cases of urticaria pigmentosa in these cats. This was also described by Silvia Colombo. Elisa is not there. You were on vacation. And then this is a case of a kitten of one of these naked breeds where I did not know what that was, to be sincere. So I thought that could have been an urticaria pigmentosa. In fact, these were the initial phase of dysplastic keratosis that in these naked breeds can evolve to squamous cell carcinoma. And this is papillomavirus associated, and they can evolve to really malignant, aggressive metastatic squamous cell carcinoma in this breed. So this is, has been described in several cats, and you can see these poor cats, these papillomaviral infections evolve to bed nodules. And here you see this is all tumoral epidermis, and the brown stain is the stain for the virus. So there is a lot of virus that causes this neoplastic transformation. Look at this poor cat. And the last thing is that these cats, they are not protected by the coat, and so they can get more hurt by environmental insults. This was a cat that was burned on a stove, and remember that they can get sunburned much easier because they don't have the hair, so they have to be really protective. Okay, so this was the first lecture on genetic diseases. Any questions?
Sandokan, the actor, is Indian.
Yeah, Kabir Bedi.
Kabir Bedi.
But you know what Sandokan is? Because this is an Italian novel.
We are worried about only Kabir Bedi, the Greek god.
Oh, you only know Kabir Bedi?
Yeah.
He was so beautiful. When he was young. I was young. I think he had blue eyes. He had very light eyes, right?
Yes.
E come si chiamava invece la Marianna lì? Carol André was the female in that movie. The actress. Carol André. Okay. Huh?
The presence of Trichorexis nodosa in trichogram. What is the pathological significance of this?
If you see, like I have shown, defects on irregular intervals, it is a genetic condition. You cannot do anything. If you just see one or two of these defects, or maybe this rupture, and this is trichorexis, not nodosa, just trichorexis, it means that the hair is worn out. So either because the owner is brushing it very heavily, or because the hair has been on the body of the dog for a long period of time, and so it's worn out. And then you have to ask yourself, why did this hair stay on the body of the dog for such a long period of time? Maybe this dog has an endocrine disease, that new hair is not growing, and the old hair is not changed. It's staying on the body for too much time. So when you see this trichorexis, either it's a cat that is leaking, but if it is a dog, you should think that maybe this dog has an endocrine disease, or if it's a Pomeranian, alopecia X, something like that.
Thank you, madam.
Okay. Now the second lecture I wanted to give you is psychogenic dermatosis in cats. So I'm talking about abnormal grooming. So we have already talked about cats that leak very much, and they do so because they have pruritus, right? But what is normal grooming? Now, cats spend between 15 and 30% of their awake time in grooming. So they sleep like 18 hours per day, so they are awake for 6 hours, and 1 hour per day they spend it leaking. So this is an incredible amount of time that they leak, and they leak for many reasons. It keeps the coat clean and healthy, but also strengthens the social bond. You may have two cats at home, and you may see that they lick each other. And this increases the bond of the colony. They share the odor, they share the microorganisms, and so on. So, licking, chewing, grooming activates some neurons. They are serotoninergic neurons, and you know that serotonin makes us feel well, right? That's why we eat chocolate, because it's full of tryptophan, which is a precursor of serotonin. It gives pleasure. Grooming, it is also exhibited in cases of stress because it just de-arouses this stress. Because it will give you pleasure, it will calm down. When I'm nervous, I am grooming my lips. I'm just taking away lots of pieces from my lips. There's people that groom their nails, right? There's people that groom their hair. This calms down. So this happens in cases of stress, and when it happens too much, it is obvious that there is too much stress. And the stress is caused by emotional conflict. For example, when a cat does not know what to do. They do not know if they have to hide or run away. They do not know if they have to attack or not attack. So they don't know how to behave. Frustration They would like to go outside. They are at the window, there is the bird there, and they cannot go out and get it. And that's really frustrating for them. Or perceived threat. For example, a dog gets at home and they don't have any place where they can hide. That can give a lot of stress. So in this case, they have stress and they behave in a strange way. And this licking, over-grooming, is a displacement behavior that redirects their emotional arousal. And that is very important because it will decrease the emotional arousal. So we have already seen that the stress is a threat to their physical or emotional balance. Physical balance, if there is a dog in the house and they have to escape, or emotional, when there is a problem they have to solve. Now, the responses to stress can be different. They can be aggressive. So when, for example, you have a cat in your clinic and you want, to say, oh, hi, nice cat, what do? They are stressed and they just attack you. It can be fleeing. It can be freezing. This is the worst one, because if a cat is frozen, he really is in a bad stress situation. Or displacement, in this case, over-grooming. So these are the possibilities, and we're talking about displacement, over-grooming, as I have mentioned in the previous slide. Now, if this stress is continuous, goes over and over and over again, this over-grooming goes over and over and over again, and it becomes a habit. It becomes a compulsive disorder, so that they will do this grooming even if there is not a stress anymore. It has already given a vicious circle in their brain, and they will displace this behavior even if there is no stress. It becomes a compulsive disorder. What is a compulsive behavior? It is a movement usually derived from a normal maintenance behavior. For example, grooming, over-licking is a normal behavior. But when it becomes compulsive, then it's too much. And it is out of context. Now, you can have animals that do this even if they are sleeping. They wake up and they start grooming. There is no stress, there is no trigger, there is nothing. It's just in their brain something has clicked because they have this compulsive disorder. It is repetitive, it is ritualistic, you cannot stop it. I myself have such a cat. When he starts grooming, he grooms a specific place on his arm. You cannot stop it. I put my hand and he's going to groom on my hand. And he is not going to stop if I want to stop them. It's exaggerated, sustained, intensive. You cannot interrupt. And of course, excessive grooming is the most common compulsive disorder we see in dermatology. There are others, but in dermatology we see this. Licking mainly, but also tail chewing or scratching. So as I said before, that grooming is not always very obvious to the owner. So sometimes the cats don't want to do it in the presence of the owner. Maybe they are punished if they groom in the presence of the owner, so they want to go under a bed or in a closet so that they are alone to do this. So the people very often do not think that it is a problem. Or if they see that the cat is grooming too much, very often they will not accept that it is a psychological problem, because having a mad family member, it is a problem. The same when the doctor says you have to send your child to the psychologist. Many parents will not accept it. So this is sometimes difficult to have the owners accept that this is a psychological problem. And to be sincere, I send very many cats to the behaviorist because I think that in many cases the dermatological problem is associated together with the behavioral problem. And to be sincere, maybe 1 out of 10 goes to the behaviorist. 1 out of 10. So I think that this should be increased, the awareness of these problems should be increased. So let us see the stress factors, the loss of territoriality. For example, if another cat comes to the house or close to the house, a move, prohibition to access of the outside. If the owners go on vacation and they put the cat in a cattery for some days, changes in the family when a new baby arrives, they are not the kings of the family anymore, absence of the owner, introduction of a new animal. So you have here a series of possibilities. And as I said, psychogenic alopecia is the problem that we see most. So we see a lot of leaking, and with time you can even cause skin lesions, because you know that the tongue of the cat is very harsh, rugged, so it can give lesions to the skin. You can even have ulcerations and crusts. So very similar to trichotillomania in humans. You see, this is all hair that has been pulled out, but sometimes you also see some small lesions that can be very similar to allergic disease. Now, this is not a normal behavior. This cat is at the veterinarian, so he should be afraid. And look, he is stressed because he is at the veterinarian's and he is biting and chewing in a compulsive way. Look at this now. He is biting, chewing, and he's pulling the hair. You see the hair that has, did you see it? He is chewing and then he's pulling the hair. You see it? That is psychogenic. That is not pruritus. That is not a dermatological problem. Here we have it again, the same cat pulling the hair. So that is obviously, and look at the violence, the intensity with which he licks. So we don't have age or sex predisposition. We think that the Oriental breeds may be predisposed because they are more nervous. Siamese, Abyssinian, Burmese, and Himalayan. Now, to us, these are Oriental. To you, these are not Oriental, because Oriental would be China, right? It's a geographical conundrum. Huh? You say Oriental even if it's... Okay, but you know, Siam is, what is Persia, right? You have it on your west part. So this should be Occidental breed. Okay, never mind. You know what I mean. Now, think that the cat has pruritus due to an allergy. Maybe he has pain due to cystitis or other problems. Maybe he has gastrointestinal dysbiosis, and all these causes are renowned to cause overgrooming, right? Pruritus or pain for cystitis or other problems. To cause overgrooming. But just imagine that you have pruritus or pain all the time. Would you not think that this is a cause of stress too? Having pruritus and having pain, having gastrointestinal problems. So this is a chronic stress. And this adds on to the overgrooming. That's why I say that many times the dermatological problems and the psychogenic problems in cats, they are often interrelated, because it then gets to a vicious circle. But then chronic stress also causes immune suppression, because if you're producing chronically a lot of steroids, because when you're stressed you produce a lot of steroids, then you can get immune suppression, right? And if you get immune suppression, you can get disease. And then it gets even a worse vicious circle. So I think that we should cut this vicious circle not only by looking at the medical disease, but also looking at the fact that the cat has stress, and we should address also the psychology of the cat. So we know that in human stress increases allergic factors like the production of IgE, eosinophils, vasoactive peptides, and so stress is able to induce urticaria, stress is able to induce pruritus. I had an owner that each time that came to me, and I had to tell her a bad news, she would start with an urticaria here because she was excited about this, emotionally excited. Opioid peptides that are produced during stress, they may potentiate pruritus. We know that stress can cause an increased epidermal permeability because it damages the barrier of the epidermis, and so we can have more penetration of allergens, more penetration of microorganisms, and also we know that we have a less efficient immune system because of the production of a lot of corticosteroids, so we have more skin infections. If we have more skin infections, we have more pruritus. If we have more pruritus, we have more stress. And then again, it's a vicious circle. So let us see what is the prevalence of self-induced alopecia in cats. There were 21 cats that were analyzed with self-induced alopecia. Of these, 3/4 had an allergy. Just 10% had only psychogenic problem, but what is interesting that of these cats, 14% had both a medical and a psychological problem. So just take into consideration that in many cases you can have the two problems together. Okay, so how do we diagnose psychogenic alopecia? Of course, we have to check for an underlying etiology. For example, we have to check if there is a neurologic or orthopedic problem. If the cat is licking, for example, the spine, they may have osteoarthritis, maybe internistic or endocrine diseases. Yesterday I told you if cats have hyperthyroidism, they may lick too much because they're hyper, also in their brains. Urinalysis and abdominal ultrasound, if they lick their abdomen, they may have cystitis, so we want to check that they don't have cystitis. And then we have to do the dermatological workup that we have mentioned yesterday with antiparasites, food allergy, and so on. You may want to do a skin biopsy, and in the skin biopsy, if it is a psychogenic alopecia, the skin is completely normal because the skin has no problem. It is the brain that has a problem. So that can help. But then it is important that you investigate the psychological causes in these cats. And so you should start to be a little bit again like Sherlock Holmes, but much more tactful, with tact, do you say this? You have to be delicate because you're getting into the psychology of the owner. So you cannot tell the owner, are you stressing your cat? Even if you see that the owner is nervous and is, oh my cat, poor cat, I'm so agitated about this cat. Now what do you think that the cat is doing? The cat is relaxed when he has an owner like that? The cat is not relaxed. And we can see immediately that this is an anxious owner, and thus the cat is not a relaxed cat. How many times do you have this? Or maybe you are a very relaxed country where everybody meditates and does yoga. We are not a very relaxed country. We see that our owners are more and more anxious, and this is getting so worse.
Cat owners are anxious for even an ordinary condition.
Yes, okay. So you understand what I mean. So you should be very delicate about questions. So you should check if there are potential stressors. Maybe the owner can take videos. And then you should analyze the pattern of these behaviors. So you have in your proceedings the slides. So you can ask questions about abnormal grooming. So how many hours a day he licks? Can you interrupt the grooming? Or is there any situation in which the cat does grooming? I had an owner. The cat was on a diet. And the owner was eating the meal, and the cat would put himself in front of the owner on the table and when he was eating, he was licking just in front of the owner. So telling the owner, you can eat and I cannot eat, and I'm very unhappy and angry about it. And then you have to ask questions about the environment. You have them on your proceedings. So is it, can the cat go and hide, for example? It is nice that the cat has some places where they can hide. Maybe these places are high because they like to be on the top and look down. And all questions regarding the life of the cat, questions regarding the owner. Are you leaving your cat alone, or are you always touching your cat and taking it? I have a daughter, she's 18, but I cannot convince her. Each time that she sees the cat, oh, nice cat, and she grabs the cat and she pets the cat, and the cats get very unhappy about it. So maybe there are children. Animals hate children because the children behave in a strange way for the animals. They are not very happy about having children at home. So another way that the cats show their psychological problem is by scratching too much. We have seen these photos already. We have seen the differentials already. Allergy, parasites. There are other non-dermatological reasons for scratching on the face. An orofacial pain syndrome, trigeminal neuralgia, dental disease. These are not dermatological problems. These are neurological or dental problems. You should be aware of this, and behavioral. And you remember yesterday we talked about this article where these cats actually have this neck lesion. It can be neuropathic, so when you give gabapentin or topiramate, we saw it yesterday, it may respond. But it may, and we have seen this already, it can also be behavioral. And as I told you, this article was very interesting because what they did is to assess the welfare of the cats. And there is a nice questionnaire that you can download from the internet, from this article. This is an open access article. You can download the questionnaire and you can administer it to your owners, and you can get a welfare score. So if you see that the score is not very high, you should advise the owner to go to a behaviorist. And most probably these lesions will improve very much because many of these are behavioral. And this is the questionnaire. You have it in your proceedings. So, for example, access to food and water resources, is it free, or the cat has to ask for food to receive food? Now, I told you I have a psychopath, right? And so I am followed by a behaviorist. And the behaviorist, the first thing he told me is, how many food bowels do you have in your house? And I said, I have just one. Oh, that's too bad. You should have at least 10. I said, what, 10? Yes, 10 food bowels, and in each food bowel the amount of a spoon that mimics a mice as the amount of food. Because the cat is very worried that he will not find the food. They eat many times during the day a small amount of food when they hunt, right? If they don't see the food around, they get very worried that they will not survive. And so by putting many bowls of food all around the house with a tiny amount of food, that makes the cat much calmer because he knows that he can find the food and he does not have to worry. I didn't think about it. Another thing is, for example, to put the litters, if you have 2 cats, you have to put 3 litters. So the number of cats plus 1. Because maybe a cat wants to go to the bathroom, there is the other cat there, and he does not allow him to go to the bathroom. And that is a source of stress. So you should have another litter. And then room and hiding place, they should have hiding place. If they cannot go outside, at least they should be able to look outside and be at the window, because I was told this is like looking at TV, so they get distracted. And relationship with the owners, activities, do the cats play or they are just getting bored all the day at home? The owner is away. I take a cat because the cat can live easily in the apartment. I don't have to look after it like the dog. I don't take a dog because I'm working all day. I have to walk the dog. The cat can be at home. But just imagine a cat being at home alone for many, many hours. That's a very boring situation. They can get crazy. Just imagine you alone in a house doing nothing, with having nobody to talk with. Less frequently, we have tail chasing and mutilation. Again, this can be stress-induced, but this also can be due to spinal pain or neuropathies. And tail chasing and biting leads to skin lesions, pruritus and pain, and this, of course, will lead to tail chasing and biting. And this is like a vicious circle. And this is my very personal cat, and he has it all. You see, he is tail chasing, and he's biting the tail. And you see, this is what he is licking always when he's stressed, this area. And now he's eating it up. You see the piece of hair that is in his mouth here. And he's licking this area. So he is hyper aroused. And this is what can happen in some cases. Now, this cat had no hair that could protect him because he was a naked cat. Hyperesthesia is another condition that can be associated to these problems in cats. Ronin skin syndrome, twitching cat disease, it could be a neurodermatitis, it can have many different origins. We don't really know very well what's the problem. Most probably it's a neurological problem, spinal disease, neuropathies, but there have been other causes that have been associated. And among these also behavioral disorders. Now we have seen these before. Look how this cat is twitching the tail. That is also a sign of being nervous, and he is having this rolling skin. You see it? Okay. I treat this usually with gabapentin. So rippling, twitching, spasm of the muscle. Some have estrus-like low rolling, tail twitching, and when they have these behaviors, they usually have very big eyes. They have mydriasis, so their brain has disconnected from the reality. You can really see when they do these things, they are looking in the vacuum. And again, they can have vocalization, running around the house with no reason, and they can also have house soil. And this is again my cat. You see the tail twitching, and you see the skin rolling. And the eyes are completely wide open. The tail twitching and the skin. I don't know if you can see the skin rolling. How the skin on the back moves. And that's another one. This is very, very cute, I think. Vacuum leaking of the dorsal lumbar area. You see? This is cute. Okay. Now, this is a nice study where they have taken 7 cats that had this hyperesthesia syndrome, and together with tail mutilation, and they were all males practically. 6 to 7 cats were males. And they have done all the tests for every disease, everything was negative, so it's pure psychological problem. They were treated with gabapentin, some were treated with topiramate, phenobarbital, amitriptyline. These are all psychotropic drugs. So what is now the general rule for the diagnosis? If you have such a cat that is over-grooming, that is chewing, that you think that can be psychogenic, you should try to rule out the other dermatological reasons, the pain reasons, for example, cystitis, neurological reasons, systemic reasons. They could have a central toxoplasmosis, for example. And then you should always think of a behavioral component But even if a medical reason has been identified, and typically a dermatological reason, they can still have a behavioral component. How do we treat them? Well, I think that they should be put in therapy by a behaviorist. This is not the task of a dermatologist. So when I get to such a conclusion that this cat may have a psychological problem, I have a good behaviorist that helps me in this, so I refer them to the behaviorist. They usually start with the behavioral therapy together with the pharmacological therapy. For example, my cat was given Clomicam together with many other things that I had to do at home. And specifically, I had the problem that I wanted to introduce a new cat at home, and that has been a big problem with a psycho cat. But we managed. And so consulting with the behaviorist is really important. What you want to do is to calm down the brain, to decrease the stress at home, so to enrich the environment and to eliminate the stressors. Okay, so that was my very last slide of this meeting. That was your very last lecture. You made it. Is there any question? Anybody has a psycho cat at home? Very interesting.
How often you advise grooming of cat?
How often my cat is grooming?
Physical owner grooming. How often you advise for grooming of cat?
I have not understood that, I'm sorry.
Grooming and bathing, madam. Actually, it is not advised for bathing, but even then, owner are insisting for bathing.
They should not be groomed, the cats. They should not go to the groomer. They should not be shampooed. They should not be touched. We are making sort of a battle with a behaviorist that she is specialized in cats. Now the last trend is to get the cats to the groomer. This should not be done. This is a big stress for the cat. It's useless. It takes away their smell. You should not bring the cats to the groomer. Don't do it. It's useless. And it's detrimental.
Thank you.
Okay.
Hello. I really thank, we have come to the end of the session, so I really thank our speakers, Dr. Kairanoli and Dr. Elisa Maina, for their fantastic, outstanding, fabulous lectures which are given to us. They have almost soaked us in the knowledge for the past 3 days. Thank you so much for your thing. I request Dr. Jayaraman and Dr. Venkateswaran to come to the stage with that. Please give we'll give gift for them as our token of love. Thank you. Please come to the stage. I request Dr. Kairanoli and Elsa Maina for. So you will have a memorable Kerala elephant there inside. Rosewood elephant is there. You can take the elephant. Yeah, you can. You can take it to your Italy. Thank you. Thank you very much for your all help and.
Thank you guys. So Goa it is. We will let you know on the group.
See, I request Dr. Kairanoli to say some few words.
So I just wanted to thank you for this invitation. And we have never received so many presents. We have never been cuddled like you have done. So it has been a wonderful experience. I thank you all, and particularly the organizers. It has really been great to be here.
Thank you very much to everybody. You were very nice. I feel like at home. You really helped me to feel comfortable, and thank you very much. You are wonderful.
I thank all the delegates from all over India who has come and having a very good cooperation and interaction with the speaker and others. And I thank Dr. Vairamuthu to support our workshop, and I thank Dr. KG Umesh and all other judges who has come, and also the persons who have come as a chairman, co-chairman and rapporteur for the research communication. I thank them, and I thank faculties from the Kerala Veterinary University for their wonderful support. And then I thank all the companies who has, without them we may not have gone to this great success. So I thank all each and every one of the company who has given very great support to us. And I thank Dr. Suraj from Kochi Pet Hospital, who is the very cooperative, and he has given a very great support to us, providing animals starting from the day one. He only we know only him in Kerala, particularly Kochi. So he is the one who has supported us. I really thank him. And also I thank Savak and Kapak for their wonderful support. And also I thank Holiday Inn staff and Mozafia, Sajid and John for helping us a lot to do this wonderful program. Last but not the least, our great IAVD team. Thank you very much for all. Thank you. We'll meet in Goa next. Okay. I expect all of you to come over to Goa. Thank you.